the Self-Insurance Claims Operations Manager for the Department of Labor and Industries. Today's event is scheduled for 4 hours with 2 10-minute breaks. And just like we do with all of our meetings here at LNI, we are going to start first with a safety tip. I find this one to be rather timely, talking about your brain on screen time. I don't know about you, but now that I'm working from home and with all of the events going on, both of health and political nature, I find myself way involved in way too much screen time these days. So here's a few facts for you to consider. So people consume 3 times as much information daily as they did in 1960. 61% of people can't ignore their electronic devices. They check them within the hour after getting an email, text, or alert. I read that and I thought to myself, ooh, an hour sounds like a really long time. So that's a check for me. 50% of people check their work email outside of work hours, including weekends and vacations. I think that this is even more tempting now that many of us are working from home, right? You pass by your laptop, you're like, oh, I'll check in just one more time. 61% of people have felt jealous, depressed, sad, or annoyed after checking updates on their social media account. 81% of people admit to interrupting conversation, mealtime, or playtime with family or friends to check their social media, text messages, or email. I know that my husband and I have made a rule for ourselves that particularly if we are out eating someplace, not that we do that much anymore, that we will put down our phones and that we will focus on our time with each other. 3 out of 5 people spend more free time on their computer than they do with their significant other. And 73% of people believe their use of electronic devices has contributed to stress in their life. So there's also a challenge on here to consider recharging yourself and to carve out some time on a weekly basis to put down the devices and just step away. So the next slide that I'll cover is just some virtual housekeeping. So the webinar is being recorded and will be posted for future access through the LNI and WSIA websites. The Q&A window and chat options can be opened using the icons at the bottom of your Zoom webinar window. Use the chat option, as many of you already have, to notify us if you're having difficulty with your audio, and we will help you troubleshoot those issues. The chat option itself will only be available to attendees during the breaks. Otherwise, besides helping with technical difficulties, to allow you to interact with our other attendees. We understand that one of the big differences between a Zoom webinar and an in-person is that we lose out on that opportunity to interact with each other. So we'll have that chat open to give you that opportunity during breaks. Please note that the private chat option will not be available. The chat log will be recorded and made available to all attendees. Please use the Q&A window to ask your questions. This will be monitored by staff, and all questions will either be answered live or saved for response after the event ends. And again, the question log, just like the chat log, will be available to all attendees. So I think that we've got a busy morning. We've got topics including COVID-19, which is of great interest to all of us right now. We'll be discussing telehealth. We'll have a panel discussion on telehealth, and we'll also have an opportunity to chat with some of the docs that are part of the Office of the Medical Director. So first this morning is a discussion, or rather a presentation, on COVID-19. First, Dr. Joel McCullough will provide some preliminary information about the disease and discuss how it is evolving. And Joel is currently an associate medical director at the Department of Labor and Industries, and he's been with us for almost 2 years. He is board certified in occupational and environmental medicine, internal medicine, and preventative medicine with over 15 years of public health practice. After Dr. McCullough shares, Starla Trevsnovsky will present some L&I workers' comp COVID-19 data, and we'll talk about risk classes. Starla is the Self-Insurance Policy Operations Manager for the Department of Labor and Industries. In her current role, she oversees policy, legislative and rule analysis, the training unit, and data collection and analysis for self-insurance. So without further ado, I will turn it over to Joel.
Great, well, thank you, Lene. For my presentation, I will be covering the spectrum of disease as it relates to COVID-19 a year old. So new information is being produced every day. And but this information that we have at this point, hopefully will be helpful in the management of the cases that you're dealing with. Next slide. So my presentation will include a little bit of background information about COVID, what it is and where it came from, et cetera. I'll also talk a little bit about how to diagnose COVID-19, mostly focusing on the different types of tests that are out there. Talk a little bit about some of the common areas that are affected, most the body parts and the organ systems that are affected. I'll touch on something called long haulers or post-COVID syndrome. It's people who have persistent symptoms of COVID after their acute infections are over, and but the symptoms continue. So I'll discuss a little bit of that. But I also want to mention that COVID is such a huge topic that can't cover everything. So I'm not going to be talking too much about the epidemiology of the disease or the different types of treatment that we have out there, vaccines, or the public health response to the pandemic, such as case investigations or contact tracings. Next slide. So few definitions first before we get started. First term that we'll discuss is coronavirus. And coronaviruses are named for the spike-like proteins on the surface of the virus. And coronaviruses are divided up into 4 different groups. And 2 of those groups infect humans and 2 of the groups only affect animals. And the coronaviruses that infect humans are the alpha coronaviruses and the beta coronaviruses. The alpha coronaviruses are the common human coronaviruses that we all see every year. They're about 15 to 30% of the common colds that we experience here in the US and around the world. Then there's the second group of coronaviruses, the beta coronaviruses, that includes SARS, which stands for Severe Acute Respiratory Syndrome, and MERS, which stands for Middle East Respiratory Syndrome. So those coronaviruses are part of, like I said earlier, are part of the beta coronaviruses, which also includes the current SARS-CoV-2 virus. And so there's some similarities, but there are also some differences between those viruses as well. So the term SARS-CoV-2 is basically the virus that's causing the current pandemic. And it was first discovered in the latter part of last year in Wuhan province. And the next term is COVID-19. So COVID-19 stands for coronavirus disease that was discovered in the year of 2019. And so COVID-19 is the disease that's caused by the SARS-CoV-2 virus. I also want to mention the term ACE2 receptors ACE2 stands for angiotensin converting enzyme 2 receptor, and that's responsible for the viral entry, the virus getting into the different types of cells. And this receptor is expressed in different body parts, and it likely plays a big role in terms of the disease and the different manifestations of disease in the different body parts. Next slide. So as you know, there is a huge spectrum of disease as it relates to COVID-19, and it goes from anywhere from the asymptomatic or pre-symptomatic to mild disease to severe disease and actually into death. According to CDC, mild disease makes up about 81% of disease. Severe disease is about 14%, and critical is about 5%. And the severity of infection appears to increase with different characteristics. Those with increasing age have a much higher rate of severe disease. Those with other medical conditions or comorbidities, as you see listed here, are at increased risk for severe disease as well. I should also say that this is not a full list of the conditions. CDC has probably about 30 different conditions that they have on their website in terms of the conditions that will increase the severity of disease. Socioeconomic factors, Blacks, Hispanics, and Asian Americans have had a disproportionate risk of disease and morbidity. And there are also some genetic factors that are being explored in terms of how they may interact with the severity as well. Next slide. So I just want to show you this slide from JAMA, and it basically shows you the severity of the different death rates by age group. And as you can see, for those who are over 85, the death rate, as you see in the fourth column, is 304 per thousand, which is hugely different than those in the younger age groups. So, and you see an increasing death rate by age group. So I just wanted you to see this major differences in the death rates by age group. Next slide. The iceberg analogy is here to kind of let you know that we only know a portion of what's going on with COVID. There's a large portion of disease and community transmission that isn't very well known. And so that is underneath the water, and we can only guess about what's going on there based on what we know that's above the water. And so I'll talk a little bit about some of the disease characteristics of what we do know, those cases with outcomes in the coming slides. Next slide. So this is just a graphic showing the viral entry and the different mechanisms of action that the SARS-CoV-2 virus can cause to impact human health. And so starting with the viral entry using the ACE2 receptor with the spike protein, viral entry and dysregulation of different aspects of the immune system, predominantly in the clotting system, that can result in disease and pathology within different organ systems. Next slide. So a simple way to think about what happens with COVID infection is kind of what happens with most people most people have a mild upper respiratory symptoms with mild symptoms in their nose and throat, and most of those people are able to clear the virus and recover within a week or so. Those who have greater loads of virus or have some other conditions or conditions that do not allow them to clear the virus may go on to have localized pneumonia and disseminated viral infections to other parts of the body. For those who are able to clear it at that point, they do recover, and that generally occurs in the second week or so. But for those who are unable to clear the virus at this point, there are other significant morbidities that may occur as it relates to the infections, cytokine storm, sepsis, DIC, multi-organ failure, etc., can occur for those who are unable to clear the virus and their body's immune system reacts in certain ways. Next slide. So this slide should be considered a summary of the whole presentation. Basically list all the different organ systems that can be impacted by COVID. And it lists some of the different diseases within organ systems that can be expressed or come out when people who are infected with COVID. More prominently those who have severe disease, but also for those who have mild or moderate disease as well. Next slide. So we all probably know that the lung is one of the more frequent body parts that's affected by COVID. And it usually manifests itself initially with cough, fever, shortness of breath. And on imaging, you can see some infiltrates on their chest X-ray or their CAT scans. Those who do not improve within the first several weeks, like we saw in the previous slides, can go on to develop respiratory failure, and they may develop what's called acute respiratory distress syndrome, which is severe inflammation of the lungs and would cause much more difficulty breathing, and often may require ventilation support. And next slide, please. So this slide shows the inflammation and scarring that occurs in different time periods. I think the main point of this is that once you get scarring of the lungs, the scarring can persist and cause significant difficulty with the respiratory system moving forward. For those who are severely affected, we don't know how long this will last, but we know that lung scarring can last a while. Next slide. So this is a CAT scan of the lungs. And if you look down on the left lower portion, you'll see what's called infiltrates and ground glass appearance in the CAT scan. And this is a typical lung finding of someone with COVID-related viral pneumonia. Next slide. This slide shows graphically all the inflammation and all the inflammatory products that are involved in fighting the virus in the lungs. So as you might imagine, with all these inflammatory cells and inflammatory mediators, if that's going on for a while, not unsuspected that there would be some lung damage and some lung scarring as a result of this pretty significant inflammatory response to fight the virus. Next slide. So the next issue we'll talk about is the hematological or blood system. There are some characteristic laboratories that you find with COVID. And let's see. And what's very common is what's called lymphopenia. And lymphopenia is the decreased number of lymphocytes in the blood system, in your blood. And it's been found that lymphopenia can occur in 67 to about 90% of hospitalized patients. And it's often used as a marker of severity of infection. So the higher amount of lymphopenia, the more severe infection you'll likely have. And the other findings are less common than lymphopenia, but they can be present. You can also see some clotting problems with people with COVID. Arterial thrombosis is less common than venous thrombosis, but you can also see catheter-related thrombosis as well from the arterial and the venous systems. Talk a little bit more about cytokine release syndrome later. Next slide. So the cardiovascular or heart manifestations, there have been a lot in the media about the potential for cardiac manifestations. It's unclear about some of the mechanisms that's involved in the heart injury, but some studies have shown that injury of the heart muscle, myocardial injury, occurs in about 7 to 28% of hospitalized patients with COVID. And so there is known injury there, and there is some speculation that the virus may directly affect the heart muscles because heart muscles do have that ACE2 receptor that I mentioned earlier. So myocardial injury, myocarditis, and arrhythmias and pathology have been described in COVID-19, but they're also described in other coronavirus infections as well, like SARS and MERS. Next slide. This slide shows some of the reported neurological manifestations. Again, some of the neurological manifestations have been found in MERS and in SARS as well. Encephalopathy has been reported fairly commonly in about 2 to 20%, depending on some studies. And also there is concern of the ongoing neurological consequences of SARS. Of COVID, and after the patients recover and no longer acutely infectious. Next slide. So this slide shows some of the kidney manifestations. A substantial number of patients with severe COVID shows some sign of some degree of kidney damage. So acute kidney injury is associated with increased mortality, up to 30% increased mortality in these patients. And those with significant injury can go on to develop end-stage renal disease and may require a kidney transplant moving forward. Hematuria, oh, go ahead. Oh, that's fine. So I want to talk a little bit about testing. That's the most common way the disease is diagnosed. So most of us have heard about the viral testing, which is nucleic acid testing. And that's the most commonly used test to diagnose COVID. And there's also antigen tests, which test for the presence of of surface proteins of the virus. And an important point is that a negative test does not mean that the test will remain negative. It depends on the window of time that you test the individuals. And also want to mention that antibody testing, which is your body's response to the infection with the production of antibodies, is not a currently recommended diagnostic test for COVID. It might show the presence of past infection. Next slide. So this slide shows you the variation over time of the different tests you use for COVID. Want to emphasize the blue line, which shows how quickly it goes up after infection, and also how quickly it goes down after its peak. So depending on what time you test for infection, you may miss the window that it's likely to be positive. So that's why there is some degree of false negative testing when you test for COVID. Next. I want to just also mention that there are some epidemiological definitions, because as I mentioned earlier, not all testing will result in confirmation of someone who is infected because of the limitations of the testing. So there are epidemiological definitions that categorize the level of positivity or level that we expect that the test will be positive, or the clinical situation warrants that they have COVID infection. So the confirmed test at the bottom, they have a positive test. Then there's the probable test that shows that they have some laboratory evidence, like a antigen test. And there's some evidence of different categories of suspect cases as well. Next slide. So again, this just emphasized the importance of the laboratory for the diagnosis of COVID. Confirmed laboratory tests with the PCR tests, and presumptive with the antigen tests, and supportive with plasma or detection of antibodies. Next slide. There's also clinical criteria for the diagnosis of COVID. So these are some of the clinical characteristics used to diagnose from an epidemiological standpoint. Having any combination of the different symptoms could put you into that category. Next slide. I think also another important characteristic, another important concept that is prevalent is the issue of dose. How big a dose do the patients receive, which may translate into the severity of their symptoms or the severity of the disease. So research is now being developed that low dose infections result in appropriate immune response with production of antibodies and viral clearance. And high dose infections, meaning a higher people inhaling more of the virus, or the virus getting more of the virus getting in their system, resulting in more immune suppression and inability to clear the virus and more severe disease. It's more complex than that, but I think the main concept is the differences between the low dose infection low mountain virus versus high mountain virus and the subsequent clinical disease you see in those different populations of patients. Next.
Dr. McCullough,
Yes.
you have about 10 minutes remaining.
All right, I'm almost done, I think.
Thank you.
There's been a lot of talk in the media about cytokine storm, and it's been linked to the severity of the disease. And so there's a lot of different cells and factors that are involved, but it more likely occurs in severe disease. And there are treatments that try to help mediate the severity of the reactions to the cytokine storm. Next slide. I just want to mention the concept of long haulers or long COVID or post-acute COVID syndrome. So some patients who recover from the acute disease go on to have persistent symptoms over time. And that's happening all over the world. And so there's a lot, this is an active area of research, not just in the US, but also other parts of the world as well. It's unclear about what the exact cause of this is. So it's like I mentioned earlier, it's being studied all over the world. One of the challenges that there's no clearly delineated consensus definition of this. So there's different ways of looking at it from different researchers. So there'll be more to come on that. Next slide. This is a graph from JAMA that shows what type of symptoms are more common in post-COVID syndrome. As you can see, shortness of breath, fatigue, joint pain, etc., are more common in those who have post-COVID syndrome versus and those then not. Again, there are other research that shows slightly different percentages for the different symptoms, but they all are showing some degree of persistence of symptoms. Next slide. Finally, I want to talk about autopsy findings because that may give us some of the clues in terms of what's going on with the patients clinically and give us more information. So in an autopsy series, they found that a lot of the patients died of infection or sepsis. Respiratory failure was very common, particularly from ARDS. Septic shock was common, heart injury was common, and blood clot abnormalities were common as well. And again, acute injury to the kidney. Next slide. So in conclusion, SARS-CoV is a disease that's associated with significant morbidity and mortality globally. And it's one of the biggest burdens of health and economic burden in the last 100 years because of the number of cases it's being caused globally. COVID-19 represents clinical forms from asymptomatic to moderate to severe, and there's still many unknowns that are still being researched. In fact, COVID infection, along with immunological response, can impact most organ systems, as we've seen earlier. And the clinical findings and pathophysiologic picture is emerging, and we'll get more information with time. That's all I have. Thank you.
So Joel, there was a question about what is disseminated intravascular coagulation.
Yeah. So disseminated intravascular coagulation is a condition in which there is increased bleeding, and it generally occurs in people with severe infections. And so there's difficulty controlling the bleeding because of the different clotting parameters are not functioning properly. And so it's a bleeding problem in those who are severely infected. Yeah.
Joel, do you think that this virus is very different in its clinical ramifications compared to the 1918, 1919 flu?
It seems like they are. I mean, the flu was the 1819, the Spanish flu. Obviously, it was a different virus. It's an influenza virus versus a coronavirus. How it, in terms of the clinical significance, influenza viruses generally play out differently. So, for example, the Spanish flu seemed to affect mostly younger people, versus this one seems to be affecting older people. I mean, obviously the lungs are target for both conditions. We don't have as much information about some of the organ system damage from the Spanish flu as is emerging now, because we have different testing and different advanced medical studies to determine some of the pathology. But yeah, but I do think there are differences, and but in terms of what the global outcome will be in terms of the number of cases, that's still to be determined.
Thank you.
Sure.
Thank you, Dr. McCullough. So now we will turn it over to Starla Trosnovsky.
Hi. Okay, I'm going to talk about some of the data that people have been curious with that we've seen from both state fund and self-insurance. Next slide. Okay. These are the risk classes, the top 10 risk classes for self-insurance that we've seen claims for. As you see, and I would probably expect hospitals are the top for self-insurance. The blue is the COVID positive claims we've seen claims for in these risk classes. The orange is the ones that are for exposure only, and the gray are the ones that we're not sure whether they were actually positive or negative. And sometimes that's because in the beginning, there weren't a lot of tests. So we were getting some folks that it was suspected, but it was hard to tell because of the tests. We do believe and know that some of the clerical office type workers are actually working in medical facilities and hospitals. Some of the other ones are first responders and other folks, nursing homes. Go ahead, next slide. Here are the top 10 risk classes reported claims for in state fund. They're slightly different. Nursing homes, again, physicians, medical clinics, boarding homes, retirement centers, colleges, again, your first responders, chore services. Again, COVID positive is in the blue and exposure only is in the orange. Next slide. Here are the COVID-19 claims numbers by determination. So of the claims that we've accepted and the claims that have been allowed for self-insurance in the blue, at the time this slide was made about 3 weeks ago, it was almost 1,200 claims have been accepted by self-insurance, about 2,100 by state fund. The number of rejected claims pretty small, 57 for self-insurance, 77 for state fund, and then we have several pending. So go ahead, next slide. These are the COVID-19 claims by claim status. So uncompensable claims, self-insured had 1,030 compensable claims. State fund has almost 1,400. Non-compensable, pretty low, 86 for self-insured, 393 for state fund. Kept on salary view. We've been fortunate, we have not got a lot of fatalities yet. And then rejected claims, 57 and 77. Pending claims, 123 and 476 for state funds. Next slide. We were asked about the days between the dates of injury and claim closure for self-insurance, and these will give you the dates. One note is a lot of times self-insured claims, there is a lag time. So some of the claims that are still showing as no decisions made, it's because they go first to the self-insurer and then to the department for the decision to reject or allow the claim. So sometimes you get a little lag time with the self-insured claims. So next slide. Okay, date of injury and claim closure for state fund. So as you're seeing, a lot of these claims are being allowed and or rejected very early on from the time we get them. Okay, go back, next slide. Any questions on the data that we've produced? I also wanted to give an update. Last week, we pulled the data for self-insurance and state fund. And state fund at that time had a total of 2,954 claims last week. So far for COVID, self-insurance had 1,463. And the total we've received between state fund and self-insurance was 4,417 claims. Thank you.
Okay. Thank you very much, Joel and Starla. We are going to take a 10-minute break now. During the break, there is going to be a couple of poll questions on the screen that will lead to the next topic of the colloquium, questions about telehealth. If you are answering other on the poll questions, please answer in the chat window. So, and the chat window will also be available for all attendees to interact and comment on the colloquium thus far. So it is 8:48. So why don't we make this a flat 9 o'clock? Give you a couple extra minutes to stand and stretch, get a cup of coffee. So we will see you back at 9 o'clock. Thank you.
Shows me.
Okay, that's fine. We just have some people who show Susan Reynolds Sherman. So if that's what your name is showing as, if you can update it to your correct name, that would be extremely helpful.
How do we figure out what we're actually showing as?
So if you click on the participants link down at the bottom of your screen, you can
Oh, it says me, I see.
Yep. So it will show what your name is, and you can hover over that and change it to who you actually are, if that makes sense.
That makes
Okay.
Lacey,
Yes.
hi, it's Jennifer. We've had several requests for the slide deck, and I'm wondering if there'll be an announcement about that at some point as to availability of that.
Yep. So Susan has that. So I think she would be the one who would know that.
I'll IM her.
Okay, perfect.
Thank you.
We will make those all available.
Okay. Thank you.
Okay, welcome back. If you didn't hear the comment that Susan just made, we've had a few inquiries about the slide deck, and they'll be made available to all attendees. So thank you for those of you that participated in the poll. We will chat more about that a little bit later and talk about the results. The next topic is telehealth with Zach Gray. This will be followed by a Q&A panel discussion moderated by Karen Jost, the program manager for health services analysis at LNI. And after the Q&A panel discussion, Dr. Morgan Young will speak about LNI telehealth policies and UW research gathering. So Zach Gray is an epidemiologist. I love that word. Isn't it a great word? An epidemiologist in the Office of the Medical Director at Labor and Industries. Zach joined LNI in 2015 and works on LNI's medical treatment guidelines and resources, along with on the department's acupuncture pilot and the master level therapist program. And so I would like to have Zach step into the camera. Thank you.
Thank you, Lene. Hello, everybody. So today I'm just going to give you a brief rundown of brief summary regarding the evidence around telehealth, some of the things we looked at as an agency even prior to the current pandemic, looking at expanding our coverage for delivery of services over a distance, and also just kind of going through some of the definitions. I know there are a lot out there and there's some confusion around it, so I just wanted to give a brief rundown on evidence and some of our own definitions. Next slide, please. So again, I'm going to talk briefly about topics where evidence exists regarding telehealth, some of the specific interests of LNI regarding telehealth, as well as a few things of concern that we may not be able to address, but we're at least being positively aware of. Next slide, please. So our definition of telehealth and telemedicine at LNI, we use those as kind of the same interchangeable terms, that they're referred to as providing those medical services over a distance using real-time video connection. So that's one of the more important parts of our definition of telehealth, is that these are not appropriate without a video connection. And if you go to the next slide, you can see that there are a lot of other definitions of telehealth that are kind of used throughout literature, throughout other organizations. This right here is a bubble taken from an AHRQ, Agency for Healthcare Research and Quality report in 2016. And so it lists some of the myriad definitions and where there's areas of overlap. You can see telemedicine and telehealth for them are used as different terminology, but also encompassing the same kind of ideas. So we just want everyone to be aware that there are other agencies and other people who are studying this and looking at this who use different definitions, but we use the terms interchangeably as an agency and require that video connection as part of it. Because I know some use telehealth or telemedicine to refer to just as, say, talking over the phone with the patient, and we don't consider that to be the same. Next slide, please. So again, I'm going to mention this 2016 Agency for Healthcare Research and Quality report. So they looked at a lot of systematic reviews regarding the delivery of different types of care via telehealth, and they found the most evidence for things like remote home monitoring for patients with chronic conditions. So this generally looked at things like heart failure, heart disease, COPD, communicating and counseling with these patients with chronic conditions, as well as providing psychotherapy as part of behavioral health. So those were the ones that they found the most evidentiary support for, both in terms of amount of evidence as well as quality of evidence. But that's not to say that there's not evidence for other conditions and things as well, and I'll get to that in a second. Next slide, please. There was also a 2018 report talked about as a rapid evidence review. This was another report looking at more systematic reviews of evidence regarding telehealth. So in that time period, they actually identified 6 additional mental and behavioral health systematic reviews published after the HRQ report, as well as looking at different areas of clinical focus. And I'll direct you here to this graphic that basically just shows the clinical areas they looked at and what they found their equivalents to as far as in-person care. based on the findings of these systematic reviews. So telehealth, telerehabilitation, teledermatology, and teleconsultation. Sorry, it's a lot of combinations of words here. But you see that they found equivalence to in-person care for all of those areas, basically, except for teleconsultation, but there's at least as a potential alternative. And I think that's an important thing to note is, in these times, while we're hoping for equivalency, if anything outperforming, that also as alternatives for delivery of services via telehealth, as well as moving forward in the future when we have access to care issues. Next slide, please. So here again is what I was talking about from the HRQ report, that there's a lot of studies out there, a lot of systematic reviews looking at various clinical areas, cardiovascular disease, behavioral health, diabetes, and how telehealth can be used in those formats. So it's a little bit of a confusing graphic, and it's a bit better in the context of the large overall report, which is a few hundred pages, and I can disseminate that if anyone wants to take a look at it. It's also freely available online. But you can see that the strength of evidence the strength of benefit goes to the right, as well as the number of patients. So the more up in the upper right-hand corner, the better there. But we can see that there's actually a decent amount of literature out there regarding these issues. Next slide, please. So some of the specific areas of interest to LNI, and I would say a lot of this also existed prior to the pandemic and this pivot to telehealth only delivered services, areas of mental or behavioral health. So there's actually significant evidence supporting teledelivery, including home-based CBT for treatment of things like post-traumatic stress disorder. There's a lot of evidence out there regarding these areas. And I think that's, if you're looking at probably, oh, sorry, can you go back? If you're looking at these areas, especially mental or behavioral health, that there's a significant amount of systematic reviews and studies out there, relatively well-conducted ones too, demonstrating the efficacy of this. Things like burn care, so both live evaluation consultation and looking at these burns via remote video technology, as well as store and forward, which is basically sending pictures or video to a safe, secure repository for later review by the provider. Amputation care, evidence is kind of limited on that one. I wasn't able to find much there, but there are some available studies that do demonstrate some equivalency of telehealth and evaluation of wounds and ulcers. And telerehabilitation. So I know one of the big interests at LNI is things like SIMP, as well as traumatic brain injuries. And I wasn't able to find a significant amount of information for that. But there is evidence supporting equivalency of telerehab to face-to-face interventions for some musculoskeletal conditions. So that's things like rehab following total joint replacements and surgeries and things like that. Next slide, please. So that's not to say that there aren't concerns around telehealth. So one thing I think you'll note if you look at all the studies is there's such a heterogeneity of these different delivery methods that if you look at that definition from that bubble, how people classify and quantify telehealth actually itself is an issue. There are potential vulnerabilities of these technologies that are based on, how good your equipment is, as well as how good your internet connection is. So you have the potential for loss of connection, video or sound, and you don't want that to be affecting the potential ability of a provider if they're looking at something like a burn wound or something like that. And again, availability of this appropriate technology. It's not always easy to get high-speed internet service. It's not easy to get appropriate technology to look at and evaluate patients. Software has issues as well. And then there's still a lot of early work going around regulatory issues, including malpractice, emergency planning, stuff like that, that if you're evaluating a patient and you have to have an emergency arises, what do you do? These are major areas of concern. And then the last one is patient privacy. Obviously, you want it to be confidential and free of outside influence. So you don't necessarily want the patient to have somebody in the room with them, or if you do, you want to be sure that they're actually free of that outside influence. I know I've actually seen some studies that actually support telehealth as a positive as far as patient privacy goes, especially in areas of mental or behavioral health, that a patient actually being able to do it from the comfort of their own home removes some sort of stigma from that, from having to go into the community, going into an office and potentially being seen entering buildings that people know these providers are at. So there are some potential positives for patient privacy as well, but it has to be weighed against some of that concern. So that's what I have for you today, just kind of a brief summary of some of the evidence lies, what our interests at LNI are, what are some areas of concerns regarding telehealth, And I hope that serves as a good primer for the panel and discussion. And I can stick around and try to answer some questions or send you links to things and send you articles and summaries as well if you'd like. But that's what I have for you today. Thank you.
Okay, anything in the Q&A for Zach?
Thank you, everyone.
Okay, so next up is our telehealth panel discussion. Karen Jost will be moderating the panel. Karen has served as Health Services Analyst Program Manager at the Washington State Department of Labor and Industry since 2014. Her background includes 30 years as a licensed physical therapist treating patients in a variety of clinical practice settings and applying her clinical experience within L&I in the return to work and health services analysis programs. Take it from there, Karen. Oh, we can't hear you.
Thank you very much. I always forget that other mute button. I'd like to go ahead and ask our panelists to go ahead and show their video so that we can see everyone and confirm that everyone's here with us. We're going to be talking today about telemedicine. And on the slide, you see here a graphic that one of our partners, whose name is escaping me right now, I'm horribly embarrassed, has developed for us. And I will come up with the name and give credit in a little while. We want to just reinforce the concept that telehealth is a lot of different modalities of delivering clinical services and monitoring services. So you'll see a lot of raindrops that show different types of technology which clinicians might use with their patients in order to engage and interact with them. Today, we're going to be focusing on telehealth, which is telemedicine, which is the little red bubble of video conferencing with providers. So a very limited focus for our discussion today, primarily so that we can help those of us who are maybe not so familiar with telemedicine and video conferencing understand some of the ways that it works really well, perhaps some of the limitations and methods that people are using to make it work effectively for them. I'd like to take an opportunity to thank all of our participants for responding on the panel or on the poll. We had about 55 responses and it shut down shortly before I was able to get all the numbers. Oh, there we go. Lacey, you were wonderful. Now we're up to 50 people that have participated in some form of telemedicine, and mostly as a patient. We have a few providers there. I do know that we had a little bit of trouble with the poll, and understand that if you answered no, you had to put something in response to number 2. So I thank everyone for your grace as we work on our technology skills. So it looks like our panelists are here. I saw Dr. Lim a little bit ago, but I don't see his video right now. Maybe he's showing up somewhere else. We're going to go ahead and get started. I'm going to introduce our panel. I'm going to introduce each of our panel members and ask them to tell us a little bit about their experience with telemedicine to date. And first up is Dr. Louis Lim, who is the Medical Director of the UW-Medicine Valley Medical Center Occupational Health Services. Dr. Lim.
Thank you very much, Karen. So I'm Louis Lim, occupational medicine physician with UW-Medicine Valley Medical Center. In terms of my experience and really our clinic's experience with telehealth, it started obviously back in sometime around March and April, probably more like April, with a rather rushed adoption given the pandemic. So we've had a couple of months under our belt. It's still been a very sharp learning curve, and in general, it's been a very positive one. Thank you.
Thank you, Dr. Lim. Our next panelist is Dr. Michael Harris, a psychologist and Chief Operations Officer at Pacific Rehabilitation Centers.
Good morning, everyone. We have had coming up on 5 years of experience using telehealth to provide behavioral and psychological services to injured workers. And in April of this year, we implemented a telehealth version of our SIMP program. We've treated about 50 patients since then, and that includes both functional restoration activities as well as pain management, education, and cognitive behavior therapy in the form of group and individual. Thank you.
Thank you, Dr. Harris, and welcome. Also joining us today is Dr. Jason Fodeman, Associate Medical Director at Labor and Industries.
Hi, Karen. Hi, everybody. I'm a internist and a primary care provider, as well as Associate Medical Director of Innovation and Outreach at LNI. And I'm going to be providing a primary care perspective on telehealth, and we'll be sharing, some of what we're hearing from our primary care providers on telehealth and their use of telehealth. So really looking forward to the discussion.
Thank you, Dr. Fodeman. Our next panelist is Izzette Swann, Doctor of Physical Therapy. She's an orthopedic outpatient physical therapist and owner of Real Rehab Sports and Physical Therapy. Izzette, you're muted.
Thank you, Karen. Thank you, everyone. Webinars are new to me, so telehealth is new to our practice. It started off with a little bit of a bang and has slipped off quite a bit. It's been an interesting process in learning about it and how to best work with patients who would prefer telehealth than in-person visits.
Thank you, Izzette. We're also pleased to have Martha Molina on our panel today. Martha is a claims administrator and workers' compensation professional, currently working with the risk and safety team at REI.
Everyone, I am going to be sharing with you some of the experience that we had as an employer with telemedicine in light of the pandemic.
Thank you, Martha. Dr. Michael Codsey was unable to join us live today. He is an orthopedic surgeon at Everett Hospital. We met with Dr. Codsey last week and have a couple of short videos from him that we'll share with you. We're going to go ahead and present the first one now. I do want to apologize that the volume on the videos is a bit low. We believe it's sufficient to understand what he's saying, and we thought his perspective was important to share with you. Susan, can we please roll the first video? Okay, so Susan, I'm not hearing Dr. Codsey. So let's do this. Rather than delay the panel, we will see if there's a way for us to get Dr. Codsey's videos available to folks so that they can hear his perspectives on the use of telemedicine as an orthopedic surgeon. At this time, we're going to invite our audience to submit questions to the panelists through the Q&A feature. Questions may be directed to the panel in general or to specific panelists. I do have some seed questions that we'll use to get us started. We have staff managing the Q&A window, and we will try to answer as many of the questions as we can live today. We'll keep a log of the entire Q&A window, and if we're unable to answer all the questions, we will answer and distribute the Q&A to all attendees after the colloquium. I got to find my questions here. All right, let's start off with, what excites you the most about telemedicine? I'm going to start off on this one with Martha.
I think that telemedicine, especially in light of the pandemic, has been a good way to continue some kind of communication, because oftentimes it's already difficult to convince the employee that they're being listened to, that they're being heard, especially with the pandemic, with everything getting shut down right away. So telemedicine gave us an opportunity to continue the conversation, continue the dialogue. So even though they weren't getting examined physically, there was still an opportunity to continue to communicate, to hear the employee, and to maintain that contact, which is something that's very important for recovery, is that the employee feels heard, and that we continue to reassure them that as soon as we're able to get them into treatment, they're going to get into treatment and physical treatment or that surgery they've been needing. So I think that telehealth definitely gives us an opportunity to continue to communicate despite all the disruption that we've experienced this year.
Thank you, Martha.
And the question.
Go ahead, Aaron.
Yes, a question has come in.
Okay, thank you. Can you read it?
It says, do you see telemed continuing at same pace post-pandemic? And if so, how does that change your practice?
Do any of our panelists want to take that one? Dr. Harris?
I certainly hope so. And the reason that I hope we continue to use it in the way we are now is that it enables us to provide scarce services to injured workers who otherwise might not be able to access those services. The technology now is so good, and the software platforms are flexible enough that we can put our services just about anywhere we need to, where there's an injured worker who needs services. So I am very hopeful that we're able to not only continue, but to expand our use to leverage the existing expertise in our medical community.
Thank you, Dr. Harris. Dr. Lim, I saw some head nodding. I'm going to use some visual cues and ask if you had anything you wanted to add to that.
So, one, I would second what Dr. Harris said, and I would just mention that from a perspective here as clinicians who treat injured workers, this has really been telehealth has been a wonderful way to access, as Dr. Harris said, limited access for especially psychological care. And so that has been wonderful. From the standpoint of treating physically injured workers, we certainly hope that this will continue. We anticipate that the volume probably has already decreased in terms of how often we're using it, as we have had a better understanding of what COVID-19 is in terms of its infectious capabilities and things like that. But I think we would definitely look to and hope that it will remain an integral part of our ways of being able to see a patient.
Izzette, would you like to comment?
Yeah, I think it's so new in the physical therapy world that we as practitioners have to actually learn to adjust our practice to be able to accommodate better patients who would benefit from it. It's difficulty. It has its challenges in terms of really being able to assess strength and exact mobility, range of motion, but it has its benefits in that you really have to look at the video of how people are moving and be able to assess their movement patterns, which is what, as physical therapists, we want to get people back to more efficient movement patterns. So it's an interesting new venue for providing treatment.
Thank you, Izzette. Aaron, are there any new questions?
Yes. Is the LNI policy that telemed is only with, quote, established, close quote, providers?
So I think I'm going to take that one for starters, and Jason maybe have some familiarity with policies as well. Our policies do allow doing new patient visits under telemedicine, and I would ask that perhaps our staff can put it in the chat box a link to our telemedicine policies, which are all currently effective through June 30th of 2021 at this time. We'll continue to evaluate that. Jason, did you have anything you wanted to add to that?
No, not at this time, Karen.
Thanks, Jason. Any other questions, Aaron?
Yes. How do we compare to other states in use of this?
Martha.
So REI is in over 40 states in the nation. So I did get some experience with telemedicine across the country this year. I did notice that other states were a little bit more quick to facilitate telemedicine and start booking those appointments with the patients. Washington State was a little bit more behind, but I did notice that toward the end of the summer, we were having a little bit more telemedicine as we were starting to open up businesses and medical facilities again. So across the nation, it was definitely rolled out a little bit quicker. I think that they have a little bit less red tape out there for their policies to execute this type of treatment. But, you know, Washington State is always looking out for the employees' best interest. So I can't blame them for the little bit of delay with rolling out the program.
Thank you, Martha. Dr. Harris.
Yes, our SIMP program is a CARP accredited program, and consequently we, from the very beginning of doing this implementation, have been talking with CARP. There are very few folks around the country, if not around the world, who are actually doing interdisciplinary pain management services. Washington is one of the few places where you can actually get that service. And so in some ways we've been behind in Washington, in other ways we've been ahead. Like I said, we've been doing behavioral health interventions using telehealth for over 5 years, and the department has enabled that and supported that and put us, I think, out in the lead with helping our workers.
Okay. I have a question I'd like to share with Dr. Lin, and I'm curious what processes you use for telemedicine when your patient has limited English proficiency and you perhaps need an interpreter.
Thank you. That's a really good question. And when we first started, we actually initially shied away from scheduling telehealth visits for patients or injured workers with limited English proficiency, out of concern about whether that would affect the quality of our communication. Since that time, however, we have actually started integrating in-person interpreters into the telehealth visits. So they become a participant basically in the Zoom meeting. And my experience with it actually is that it's actually gone on quite well. I think it has helped if there is a consistency in the interpreter. And what I mean by that is that the interpreter has an established relationship with the patient. I think it helps somewhat for them to really have a kind of a, should I say, working relationship between the patient and interpreter and the interpreter and the clinician. And I really haven't seen a deterioration, I think, in the communication aspect with the use of live interpreters on a telehealth visit.
Thank you very much. Dr. Harris, I see you nodding. You have some experience using interpreters?
Yes, absolutely. For those of you who are not familiar with the Zoom professional platform, there are adjustments and features in that allow you to use interpreters in a way that is much like the United Nations uses interpreters, only you can have two-way communication. So we have been using live interpreters since we started our virtual or telehealth SIM program a number of months ago. And our experience is, as Dr. Lim said, that it appears to, there is no obvious detriment to the patient or the process by organizing it and using it through a system like Zoom.
Thank you. Does anyone else have observations about the use of interpreters? All right. Aaron, do you have some additional questions?
I do. Have you found improved health equity access with increased telemed?
Anybody got some perspectives there?
I think it can go both ways. You know, you have people who have access to technology. You're making the assumption that everyone has access to at least a smartphone with a good broadband to communicate and participate in telehealth, but that it doesn't necessarily mean they know how to use it. And some people still use their little flip phones, and they have to go outside home to try to find a way to communicate for telehealth, which, you know, turns into an inconvenience if they don't have that access. So I would say it goes both ways. I don't think we're at a point where we can say that it's equitable. I think that if it was equitable, the medical provider would have or you know, the state, the insurer would have a way for them to have a tool, like, I don't know, like a phone or a tablet that they could check out to participate and have, oh, Dr. Harris has that. So they could participate and have access to a good connection. So Dr. Harris is providing that, but that doesn't mean that everyone is. I know that for our injured workers, I did have to explain a couple of times how they could use their phone to participate in telehealth. They were having a difficult time understanding the doctor's instructions. But I mean, it's new. We're just starting out, so there's a lot of opportunity to get to an equitable point.
Anyone have anything they'd like to add there?
I would second what Martha said. I think there are certainly significant issues with equity and access, and you know, it runs the gamut from the infrastructure aspect of it, socioeconomic status and well-being, and also geographical location. And any of these things, you know, can really affect access to broadband, and it really does put these individuals at a disadvantage. And to a lesser extent, age even, because again, familiarity with you know, technology, smartphones, and you know, apps like Zoom.
I think all of those are valid barriers, and as an organization, we have taken them head on. We provide tablets to the folks who do not have devices in their homes. We have some cellular tablets. We do practice sessions with every patient before we attempt to do an evaluation or an intervention. We've even done some things like made arrangements in community organizations, like the Department of Health over near Dayton was able to give us a secure room where we could do an evaluation with the patient. So I think there are challenges to providing equitable services, and the good news about the virus is that it is driving us to find the methods that work to provide these things. And I am very pleased with how we've been able to get through a lot of these barriers, and hopeful that the community in general will be able to do that.
You know, I would just like to follow up on that. And I just want to say, I want to commend Dr. Harris and his team for being so aggressive with addressing this issue of access and equity. I mean, that is really impressive. I feel like you really should provide us a best practice guidance document on this for all of us. That really sounds like wow, that's impressive.
Thank you. We've worked hard at it. It's important to us, and it's a service that we believe the injured workers in Washington really need.
I thank you, Dr. Lim, for that acknowledgement, and for all of you for sharing your perspectives on this. I think one of the things that has struck me the most about the pandemic is it has really, this disruption. I mean, it's just an intense disruption for everyone in the way we live and interact, period. And it has caused us to really innovate in ways to continue to achieve the goals that we have. And so I will take an opportunity to acknowledge the hard work that our staff have done to get our policies up and running so that our workers could continue to get services. Aaron, do we have more questions?
We do. Do you feel that telemedicine is limited for mental health care, specifically as the provider may not be able to see the entire body language of the patient? If yes, how may that impact the provider's full assessment and recommended plan?
Look to some of our clinicians for that.
I can do this, Karen. I mean, that's a really great question. You know, we're hearing from our primary care providers that mental health is actually one of the best visit types, you know, for telehealth and where telehealth is used. So, you know, that's what, you know, we've been hearing. I definitely would, you know, agree that, you know, there are, you know, limitations and, you know, specifically, you know, not being in the room, you know, not having the same access to body language and just kind of the overall, you know, gestalt, you know, can be a treating limitation for treating, you know, mental health conditions, you know, and, you know, other conditions we're hearing from our primary care providers. But then at the same time, you know, we're also hearing that getting to see the patient, you know, in their home and having that unique information and, you know, insight can add other value to the assessment and, you know, treating plans. So I think it's, you know, somewhat of a trade-off, but, you know, overall, at least, you know, what you know, I've been hearing is that, you know, mental health is, you know, one of the, you know, visit types where telemedicine, you know, works, you know, works really well.
Thank you, Dr. Fodeman. More questions, Aaron?
Yes. Does the option of telemed give a greater selection for specialists to perform an exam or IME with the option of working with physicians either nationally or even internationally?
In theory.
Anybody have any thoughts?
I think
Can you expand on that?
In theory, it absolutely does. However, there are some logistics and technical issues and challenges that we will have to overcome before that becomes a day-to-day reality.
Can you expand on what some of those challenges might be?
Yeah, for one thing, right now, not everyone is using the same platform or a compatible software platform. There are the obvious restrictions of language and arranging for interpretation. We're getting better and better at those two areas. Most people, I think, these days are using Zoom Professional or Enterprise, I would assume. I mean, it's the most widely used and secure platform of which I am aware. But language, technology are some of the challenges. Comfort with the process on the other end, the patient. That takes some prep work with them. It takes some informed consent with them. Just can't launch into these things without discussing the risks and benefits of the treatment and getting their approval for it. So those are some of the barriers.
Have any of our panelists had an opportunity to see any like, I would consider this like a distant consultation. So you'd have the patient as well as the primary clinician and then the consulting clinician. Have any of you had an opportunity to see any of that or participate? Okay, great question. It continues to expand our horizons. Aaron, are there more questions?
Yes. Are there areas where telehealth is not as effective or useful for treatment?
Izzette, do you have any comments on this one?
Yeah, I think that it's hard in the physical therapy situation because there's so much that requires hands-on guidance or hands-on mobility work. And so and hands-on strength testing. You can do a lot with telehealth. So I could see it as being something where you could have a few visits of telehealth, but checking in person would be really beneficial for the patient in terms of making progress, and then also for the therapists, for labor and industries to see that actual progress is being made. Like I said earlier, it is stretching us to look beyond what we're used to doing and saying, okay, how can we take this method of treatment and working with somebody without putting our hands on them and challenge ourselves to be a practitioner that will benefit the patient in that way, but not everybody will benefit that way.
So sort of a corollary question there is the whole conversation about objective medical findings, which is a key component of information that claim managers need in order to make workers' compensation decisions at this point. That's one of the concerns that we hear consistently is how do you get objective medical findings in a telemedicine visit? So I'd ask our clinicians if they have some thoughts around that. Dr. Lim?
Well, I think it's a really, really good question. I think this is again an evolving area where we're learning really as we try to implement, and we can glean some limited objective findings based on a telehealth visit, but the reality is mostly limited to range of motion, observation of the injured area, again limited. But certainly, I think where there is a need for a detailed physical exam is where, for now, at least for me, I find that telehealth comes up short. And so in terms of especially the initial assessment of an injured worker, where especially if it's a musculoskeletal type injury, I think the ideal would still be an in-person clinic assessment. And also I think the other kind of subset of patients that we would likely really need to follow up in person are patients who are on a treatment plan but are not improving as expected. I mean, I think when that occurs, there really is a need to have an in-person reassessment, a reassessment physical examination, and sometimes that one-on-one face conversation about what's happening and what the barriers might be.
Dr. Harris, you do rehabilitation, and Izzette's observed that there's some challenges and limitations there. So how do your team go about getting objective findings and documenting progress?
Great question. And I have to say that it is an area where, as Izzette has indicated, we are growing, learning, and developing methods that push us. I think to the extent that an exam needs lab findings or hands-on exam or even some very close-up work, although dermatology has been using telehealth for a long time. There are special cameras and so on that are used regularly. What we do is that we provide each of our patients with a bundle of equipment before they start treatment, including some known some objects that have known weights and sizes. And so as we are working with them on their functional restoration, we can observe them, for example, lift a gallon of water. It's part of their OT circuit. We know that a gallon of water weighs 8 pounds. We can also ask them to do this, and we can see that. And for shoulder patients, for example, although that doesn't give us the same thing as a goniometer, it does allow us to say the patient was able to put his or her arm up above their shoulder or whatever. So our physiatrists are learning ways of doing this from a distance to do it, even initial evals on chronic benign musculoskeletal pain patients. Now that is a much different bunch than Dr. Lim was talking about, where you've got a new back injury or something. I think, as we've said several times, this method lends itself to certain kinds of interventions better than it does others. And we are getting better and better at providing objective information about function and assessing the patient's progress.
Thank you. Izzette, you have some thoughts?
Yeah, I think that Dr. Harris makes some great points. I think that in terms of physical rehabilitation and what has traditionally been the thought of what we do is we test for range of motion and we test for strength, and is changing that paradigm from just strength and range of motion to what is the function. And, you know, if we're working with injured workers, the whole idea is to get them back to function. So changing our mindsets and everybody's mindsets to, it doesn't need to be a 5 out of 5 strength. It needs to be, can I squat with good mechanics and lift up 50 pounds? Because that's what's going to get them back to work. And so really, it's a mindset change of a whole lot of people in what traditional physical rehabilitation medicine is about, and moving toward function, return to function, and that is the emphasis. So, you know, sheets of paper that I fill out and range of motion and strength, that's great, but does it improve their function?
Thank you. Martha, do you have any observations on, as a claims administrator or someone looking for information about your patient's progress, your claimant's progress?
I think that it's too soon to tell from my experience. A lot of the claims that had telehealth services were claims that were already active when I started with REI. I just started with REI in March of this year. So I didn't really know, like, unless it was a very complicated claim, I didn't really know the history of the claim. So I couldn't really tell the difference as to, was it working, was it not working? The thing that I can confirm, the injured workers did appreciate the communication that was still happening. So they felt like they were being heard, and that made them feel a little bit better about the situation, because many of them were scheduled for surgery in March or April, and they wanted to continue their treatment. I think that there's opportunity to see it grow, but I think that from an employer perspective, it's too soon to tell.
Thank you. Aaron, do we have more questions? Oh,
Karen, I'd
Harris.
like to make a comment. We haven't really talked about this, but we have been doing daily satisfaction surveys with our SIMP patients. They fill out a satisfaction form every day for the time they're in treatment. So we have nearly 800 surveys that ask questions like, were you satisfied with today's treatment? Did the technology work okay? Did the session today help you move towards return to work? Did it help you with other items? And overwhelmingly, the patients who are participating in this are doing ratings that are very favorable. I mean, we're in the high 90s with satisfaction with the intervention. And I think that is something worth mentioning. Having, being an effective provider, part of that is that your worker or your patient is also pleased and satisfied with the intervention, and that is overwhelmingly the case with the intervention we're currently using.
Anybody else doing post-visit? Jason?
Just to add to what's been said, Karen, I think there's no question that, the physical exam, those objective findings, is a challenge with telehealth and a limitation. And, there's, we're hearing some variation, of that limitation from different primary care providers, but there's no question that it is a challenge and a limitation. But then, I would also say to kind of, what we're, been hearing, from Dr. Harris and, from others on this call, on the panel is, there's really a tremendous amount of, an opportunity for creativity, an opportunity for ingenuity, an opportunity, for leadership and, to kind of, meet that challenge and, to best, get our patients and workers the best care. And, obviously this is, very much evolving, but, I think that, creativity and, that kind of ingenuity is, very, very exciting.
Thank you, Jason. Dr. Lim.
Yeah, and to share a little bit more, from the injured workers' perspective that Dr. Harris alluded to, at a practical level, for those injured workers who have access and do not face, the socioeconomic infrastructure technology limitations, they are largely, they find telehealth visits to be very, convenient and economic, because many injured workers are not paid when they have to take 4 hours off work to see a clinician or to follow up with a clinician. And so this really allows them to continue to stay on the job, take that 15 to 20 minutes out, but continue to remain paid and not have to travel. So there's really a socioeconomic benefit, especially in a time like this, for many injured workers.
Thank you for that.
There have been no known cases of COVID transfer via Zoom. I mentioned
I can count on you, Dr. Harris.
It is safe, Lewis or Dr. Lim, and not only is it convenient and economical, it is 100% guaranteed to prevent the virus from spreading.
That's a really valuable reinforcing point. Thank you very much for that. We're keeping people safe.
Yes.
Aaron, more questions?
Yes, it has been difficult to find a behavioral health telemed provider that is accepting new patients or who is taking on additional L&I patients. Are you working on expanding behavioral med provider access?
I'm not certain who the question is directed to. Does anyone have any thoughts on it before I comment? So behavioral health access has been a chronic problem nationwide, I believe. And so it's not entirely surprising that we're having difficulty finding somebody to see a patient that has behavioral health needs. The department has a master's level therapist program coverage available now for behavioral health services. And so it may be an opportunity there where we are testing the master's level services. And I think Morgan put a note in the chat that shares some information about that. And so we are hopeful, and this pilot for master's level therapists is up to a 4-year pilot. So we are seriously looking at how can we expand access to those needed services. It's absolutely very important. I think the acuity of the problem is dramatically increased with the pandemic. I can tell you that personally, I've struggled a lot psychologically with the isolation, and I'm confident that I'm not alone. So everything we can do to help people get access to that kind of support is incredibly important. Martha, any perspectives there?
I mean, just personally, I'm an extrovert, so like, yeah, the whole being in lockdown thing was difficult, and the way that I did cope with it with talking to a therapist through telemedicine. So that was very helpful. Like, I didn't have disruption in my personal care, and also just FaceTiming friends to kind of like continue to interact with other human beings besides my husband and my dogs. So, you know, it turns into a very odd place, but I mean, there's definitely ways to cope, and you know, we're all on the struggle bus in one way or another. My best friend, she's an introvert, so for her, this is like her thriving time. She's recharging all she can, and that's something that I also take into account when I'm listening to my injured workers. That I listen to them, and I'm like, okay, is this person an introvert? Is this person an extrovert? Where is their struggle coming from? And that's something that I communicate to our claims adjudicators to say, hey, this person is also struggling with this. Can we see, you know, if the doctor can comment on this? Just because, you know, the doctor tends to advocate for the injured worker, but if the injured worker doesn't know that they're experiencing something on the side that is not claim related, but they can bring it up to them. And if they're with an employer that has an EAP program, they can bring that up to them as like, hey, you know, talk to your employer, to your HR, do you have an EAP program so you can continue to progress? Because you don't want your claim progress to be stalled out just because of, you know, they're having mental health issues due to the pandemic and the isolation and all the other struggles that come with the pandemic right now.
Thank you for that. Dr. Lim, and then we'll go to Izzette.
And just to respond to a specific angle of that question about access, while definitely psychology and psychiatry access has always been a challenge and remains a challenge, the use of telehealth has actually facilitated more access, just because what was previously geographical barriers of travel is no longer the case. As an example, from my clinic, I've been able to connect 2 injured workers for PTSD type treatment, EMDR specifically, where I previously, I mean, believe it or not, could not find a clinician providing that in the greater Seattle area. But we were able to connect them with someone in the South Side.
Thank you. Izzette?
I think the in-clinic visits have been really interesting lately because we, as physical therapists, also oftentimes are kind of counselors. And so that one-on-one, that person-to-person, face-to-face interaction for a lot of people, we have picked up on tends toward depression, where we have a discussion with them and give them resources to be able to reach out and contact their primary care physician. And you may not pick up on that in a telehealth, but face-to-face, you can really pick up on a lot. So there's this balance in all of these stressful times of, you know, that face-to-face for a lot of people that we see, it's their one outlet where they actually get to talk to somebody outside of their little pod, and the relief that they feel. And we have a really big clinic. It's very spread out. We've limited the number of therapists, so we limit the number of patients in, and we feel like we provide a safe environment for people to come in. And so there's that balance of like, how much do you just, is the distance, we're already socially distancing, and now we're distancing even more with telehealth, versus providing safe environments for people to be able to come in and have some one-on-one interaction.
Definitely some plus sides for telehealth as well as for the face-to-face. Martha, it's interesting that you noted that you're an extrovert and that this has been challenging for you. I'm very much an introvert, and I too thought that, oh, you know, this will just be my time to recharge, but that hasn't been the case at all for me. This has been very difficult. So I think describing the introvert extrovert is a good starting point, but it's been a very different experience for everyone, I think, and encouraging people to talk about it in their conversations, whether it's via telehealth or in-person visits, is important, because that's how we process. I really think whoever asked that question, it was a really good spark for conversation. Aaron, have we got some more?
We do. What areas of telehealth delivery medicine do you see as being most effective and least effective?
Great. Anyone want to take that one to start?
I could take.
Processing. Thanks, Jason.
You know, I think we're hearing that telehealth is really best suited for kind of circumstances where there's really less emphasis on the physical exam and objective findings, and when there's, you know, kind of less likely that the exam is going to change clinical management. So conditions like mental health conditions, visit types like lab follow-up, counseling, you know, those are the sorts of visit types that at least, you know, I've been hearing from some of our primary care providers that that's where, you know, telehealth, you know, is most effective.
I think that it's ultimately up to the players to determine kind of how the telehealth is going to pan out. Because if you have an injured worker who's willing to participate in this new experience, and you have a provider that is willing to participate in this experience, and they're both giving it their 100%, whatever trial and error is happening in between, they're going to make the most out of the situation. And the same goes, you know, for the flip side. You have an injured worker who doesn't want to participate, or a provider that is just very unsure of the experience, then it's not going to have the best outcome as it would if both parties were completely involved in how they're going to participate in telehealth. And with our injured workers, I saw it both ways, particularly, I would say in the state of Arizona, there was definitely both types of providers, the providers that were not very interested in participating in telehealth, but that's the only option that they had available, and injured workers who were not interested in participating in telehealth because they felt like they weren't getting anything out of it. So there's definitely the social aspect of telehealth, not just, you know, is the medical provider equipped to provide the service, or is the injured employee equipped to have the digital access to participate. There's also definitely a social aspect that we don't control, and we have to also weigh in on that when we're looking at the effectiveness of telehealth as a whole. Because I even had one injured employee who she did test positive for COVID, so her physical therapy had to be placed on hold. And she was very, very amped, like she had mild symptoms. She didn't want to stop her treatment. But of course, the physical therapy center was like, no, you tested positive. We are not going to treat you until you test negative. And they were able to provide her with a home exercise program and still participate with telehealth for her physical therapy because she was very animated. The physical therapy center was a little bit skeptical, but when they saw that she was enthusiastic of the participation aspect of it, they were like, okay, we'll bite. We'll give you something to work on for the next 3 weeks until we can get a second test from you to see if you've tested negative. So I think there's, telemedicine, we just think about access and who's the provider equipped, but there's a whole social aspect that we also have to weigh in on.
Where there's a will, there's a way. Anybody else want to comment on this one? Dr. Harris.
Just like for those of you who have children who are doing telehealth academic pursuits, the educators were smart enough to know that social aspect is very important if using this modality. And so most of especially in the elementary schools, most of the teachers spend time having activities that promote the social interaction among the folks on the screen. In fact, we recently we're looking at a quality improvement program where we actually do that with our sim folks a little bit more to make the group effectiveness a little more potent. And so I think that's an important part of any kind of program you put together, is to be mindful of that.
Thank you. Aaron, more questions?
Yes. What if IMEs included the option of a Zoom follow-up discussion with the worker, AP, and IME?
Anybody have thoughts or comments on that? I'm not quite certain myself if that's a follow-up just to kind of close the loop and support closure on the IME findings and agreement. I'm not entirely sure. Does anybody have any thoughts? I don't know that it's something we'd be opposed to. I think we probably have an interesting concept to whoever's asked the question, if you could share it. We have it recorded, and we're going to be doing some rulemaking on IMEs and telemedicine, so that might be an opportunity for us to explore a little bit more fully. Dr. Lim, did you have something?
Just a thought. So my practice currently is to definitely review the IME with the injured worker, preferably in person. So although telehealth is an option, so definitely want to do that. In terms of including the independent medical examiner, it sounds like a great idea, to be honest with you. Often we're, I think with good reports, it's clear. Sometimes the reports are not necessarily as clear. So maybe it certainly would be helpful.
It's an interesting concept. So I appreciate the question. Any more, Aaron?
Yes. Have any of you anticipated or been faced with any liability scenarios using telemedicine? How have you prepared for such scenarios?
I'm going to look to our clinicians for that. Dr. Harris?
Yes, especially prepared for. As you may know, we're treating these folks in their homes, and there are some special issues that go with that. And that is our ability to watch them closely as they do the physical movement involved in rehab is sort of limited. So we put a lot of front end work into talking with them about what to do. We go over the physical space where they're moving around to make sure that it's safe. We do several layers of education and informed consent with them, talk to them about a 911 call should they need to do it, and have tried to anticipate the areas where there might be problems. Fortunately, I just knocked on my desk. We haven't had any specific issues develop. And it's always a high risk group of folks. The chronic pain folks, they don't move, they are fearful, and so on and so forth. So we've had to be very vigilant and careful.
Thank you. Izzette?
We've had to do the same thing in terms of policies and procedures and education before starting telehealth, because you just don't know if somebody's going to fall down doing something. You want to make sure that they understand the possible risks and that they understand they have the setup appropriate to minimize any risk of injury to themselves.
Yeah.
Great. So I'm going to take one more question if we've got it, and then we'll wrap up.
Okay.
Aaron.
Last March/April, we were hit with this need for telemedicine, which I'm so grateful for as a means for continued care to our injured workers. Is there discussion regarding standardizing telemedicine across healthcare? How do we know in the management of these claims that these various telemedicine resources are delivering quality care?
Anybody have thoughts on that one?
Oh, I think in some ways that's a perfect segue into what Dr. Young is going to talk about next.
That was going to be my observation, but I didn't want to limit the discussion.
Yeah, well,
maybe.
Yes, to answer the question, yes, the ATA, which is the American Telehealth Association, is an incredibly rich resource for issues like this. There are all sorts of quality movements afoot. We ourselves are required by CARF to do quarterly assessments of quality and outcomes and provide quality improvement plans, and we're working on those. There's some areas where we know we need to fix things a little, and that's the case, I think, for most healthcare interventions. But the answer is yes. There is a tremendous movement afoot to get things standardized, to enhance the quality of what we're doing, to advance the technology, the software platforms. I mean, it's an enormous enterprise right now.
Thank you. Dr. Fodeman, did you have something you wanted to share?
Well, other than to say that I agree. I think that's a nice transition to Dr. Young's presentation.
Okay.
But you know, I would say that you know, I think you know, telemedicine has a lot of you know, potential, and there are upsides, you know, particularly to you know, increasing access and to you know, connecting demand with you know, scarce resource, as we kind of talked about. But then, you know, at the same time, you know, as this question alluded to, you know, as did the last question, you know, there are a lot of, you know, very legitimate, you know, issues, you know, and concerns, you know, raised, and, you know, and I think those things, you know, definitely are, you know, very, you know, serious and legitimate, and, you know, need to be, you know, hashed out further. And, you know, this is a, you know, very much, you know, an evolving space that, you know, warrants, you know, additional evaluation that I think we're gonna hear a little bit more about now.
Thank you very much. A couple follow-ups on that particular question. I do know that there is and I'm going to get the name wrong. I'll find a link and get it into the Q&A for folks, or put it in chat during a break. Northwest Telehealth Resource Center that does a lot of continuing education and providing information on telehealth in the Northwest. And it's not just Washington, it's like Washington, Oregon, Idaho, Montana, I believe. And then Washington has a telehealth collaborative that was mandated by the legislature several years ago. There have been legislative bills surrounding telemedicine, I think most recently on payment parity. So there is a lot of policy conversation about telemedicine, telehealth going on today. I want to thank our panelists for joining us today. I greatly appreciate all of your expertise and insights. And I want to make sure I pause and say thank you to Tricia Daniel from WSIA for her support on the graphic design of our umbrella and the raindrops. And thank you, Martha, for helping me remember the name. We have a couple Daniels that I was afraid I'd get the wrong one. So Tricia, thank you very much for that support. I'm going to end the panel here and we'll turn it over to Lene to get us off on our next presentation.
Great, thanks, Karen. That was a fantastic panel. I hope that everyone enjoyed that and that you learned something, have some information to take back with you. So next up is Morgan Young. Morgan is going to discuss L&I telehealth policies and UW research data gathering. Morgan is the Associate Medical Director for Chiropractic at the Washington State Department of Labor and Industries. His position involves evidence-informed policy development and quality oversight regarding conservative care of occupationally injured workers. I would like to introduce Dr. Young.
Thank you, Lene. And thanks everybody for having me. I think that was a perfect segue to my talk. And there's just one point on that. I think that as we're learning how to function in telehealth, whether it's through meetings or as providers, it's a modality for delivering care. The same way as you have a bedside manner with your patients in office, there's a telehealth bedside manner as well that some providers are going to be good at and others aren't, and there may be skills we need to develop for that. So it's an ongoing process, and I think some people are doing it more than others. One of the reasons I'm part of telehealth is that my practice history is that I worked in Silicon Valley for 8 years, and so I was at Cisco Systems in their on-site health system. And we did telehealth for teledermatology. We also did it for follow-up visits for our patients just at their desk, as well as figuring out how to implement chiropractic physical therapy into that. We also did telehealth to North Carolina, one of our sister clinics there, and one to Bangalore in India. So we've been experimenting with telehealth and in that system for a long time, and I'm trying to bring that expertise to L&I. And part of that is looking at these policies. So if we go to the next slide, there's a little overview about early in the pandemic, we did implement a bunch of temporary telehealth coverage. Now we had policies beforehand, and I think those we've linked to those. I'll just throw it in the chat again here. Those are our temporary telehealth policies. We've had telehealth policies for many, many years pre-pandemic, but there were a few limitations for the pandemic that we needed to address. So allowing home as an origination site was one of the big changes, rather than only at medical centers. And I think that's something to keep in mind for an access issue too, is that there are ways to do telehealth, not from your own smart device, but there are places that you can go do that. Dr. Harris mentioned getting some of those set up in the community and ways to create that resource. Initial evaluations were allowed. So somebody asked earlier about whether you had to be an established patient or not. You used to have to be an established patient. Now you can initiate care through telehealth, and then claims initiation, filing of the report of accident, and also for activity prescription forms. So those were the big changes that we implemented in March and April, and our payment policy team worked very hard on that to get that up and in place as quickly as possible. And now we have extended it to 2021, and we're taking that year to kind of look at these policies and see how do they address the need that we needed in pandemic, and how do they work for us long term? And how do we ensure quality care and proper use of these telehealth policies? What kinds of tweaks and changes do we need to have? All right, next slide. So some of the services we specifically allowed were also telerehab. We came up with another telerehab policy on that one, allowing the eval, re-eval, and things that you could services you could perform through visual or verbal cues. As Dr. Harris suggested, there's a lot of creativity happening here on how do you deliver therapeutic exercise across video and engage people in what they're doing. Work hardening, structured intensive multidisciplinary programs, SIMPs, we allowed those to happen in certain capacities, as well as behavioral health visits, both group and individual, and some brain injury rehab components about how they treat and evaluate their workers. And next slide. And then interpreter services, as was mentioned a couple times, about how do we get interpreters into these either in person or linked in through Zoom to get those patients their needed services. Independent medical evals, mental health, dermatology, and speech are the limitations on that currently. There is an IME work group looking at those pieces too. And each of these services I've just talked about has its own specific telehealth policy that I linked to. You can take a look at those if you want any of the details on those particular policies. All right, next slide. So to that end of looking at how do we move forward long-term with an updated telehealth policy that meets all these needs, we contracted with the University of Washington, Deb Folden-Kehoe and her project team there, put together with a number of providers that are doing telehealth at Harborview and other UW centers, as well as research analysts, and then myself as the subject matter expert for the contract. So I'm going to pause right here for a second and see if there are any questions particular to our temporary health policies that I can answer, or before we move on to some other kinds of questions. So I see Dr. Slutsky has the question around using places other than home with telehealth resources and private rooms to be an origination site. So we don't limit that necessarily at the moment through our policies, because once we've allowed home as that origination site, there's not a strict definition for home yet. And maybe that's something that we need to evaluate. That home just means wherever that person is at with their device and is calling in from. And I think that presents some unique challenges. One little limitation we did put on that was that if they were going to make that call from an employer's site, that employer's site needed to be a healthcare facility that was run by that healthcare provider, ensuring a little bit of protection from potential coercion that might happen if you're calling from your boss's office. Other than that, we don't have much restriction on that, but that's a question for the future of, is that something we need to limit or change or define of what home means? A point that comes up a lot from working with Cisco in Stanford dermatology is, the difference between what is telehealth, delivered from your phone in your car in the parking lot is a much different experience than at a healthcare facility with a nurse and a high definition camera delivered through a high bandwidth line. These are very different implementations of telehealth and may require different kinds of service levels. How often are we meeting to review and update the current telehealth policies? I speak regularly with Megan Lemon and Emily Stinson that are online right now, answering some of these questions. We meet and answer and discuss and collect all these things that come up. And I know in the other telehealth policies, Dr. Fodeman and others are working on collecting what are the issues and things that come up from providers, from workers, from a policy standpoint, and putting those all together. And part of what I'm going to do today is get your feedback on what questions do you think need to be answered in our UW telehealth evaluation so that we can have that future telehealth policy meet everybody's needs. Good question. I don't know that we've made any significant updates recently to the telehealth since about June because we took a very broad approach to give as much access as possible during the pandemic. And now we're refining that about what do we need long-term and how are those situations different. Okay, no other questions particular to telehealth policies. So I'm going to move to my next slide. And a little bit about the evaluation and the plan components. So we have a couple pieces to this. We're looking quantitatively at the administrative medical billing data, time loss data, things like that that the department can access internally. Detailed utilization of the types of services that people provide, what level of care, new versus established patients, which kind of provider types are using telehealth and for what, and then also the patient characteristics wherever we can glean that data. The demographics that we have available, what types of conditions they're being seen for, the accepted diagnosis codes, and what their origination site was. So we're trying to learn as much as we can about how are people actually using it. And then when we get to comparative analysis, we're going to try to look at workers receiving telehealth on those same kinds of issues. How does it affect their access to care, their claim progression, costs, visit frequency, patient characteristics, what kind of provider types were more or less likely to use that, and how about timeliness of access. The point was brought up earlier, I think by Dr. Lim, around the ease and the time savings of which to get into that visit. And also, sitting around in your doctor's office, the telehealth visits tend to move forward a little more rapidly with less wait time. So I think there are some definite advantages for patients there. We're going to look at those components. And then the qualitative component of this, we're going to look towards key informant interviews, structured surveys, both from employers, workers, providers, all of the people involved in telehealth. Looking at the appropriateness of use, was it always used properly? One of the fears is around the duplicate services of visits. If you call up and have broken your arm and they say, yep, you broke your arm, you need to go to the emergency room, was that an efficient use of healthcare services? Barriers that people encounter to using telehealth, I think the tech side has been mentioned a couple times, and how are people coming up with creative ways to deal with that, like issuing devices, creating community partnerships of places that people can go to use equipment. All of those are great ideas. And what kind of patient characteristics they see that are either willing to perform telehealth or not willing to perform telehealth. How people are doing informed consent. I think there's a lot of variety in our systems right now. And I think Dr. Harris is a great model of ensuring that informed consent around, is this meeting your needs? How do we move forward? Is everything working for you? Rather than just ignoring that piece. And what types of technology are people using? Both platforms, what's the worker using, their computer or their phone? How does that affect the quality of the visit and the care? And what kind of equipment are providers using? Good, so let's go to the next slide, and then I want to get some questions from all of you. You can just type these into the Q&A. I don't know that I'll have a specific answer for any of them, but we can have a little discussion about it. And we just want to collect this, because as we go forward with this pilot, we want to make sure that all of the questions from multiple viewpoints are answered. Tricia had a great one earlier around how does this affect quality? And I think that's exactly the kinds of questions that we're going to try to answer with this project is, we don't know. And one of my hunches is that it's going to depend a lot upon the providers. Another theme that came up earlier was, if the patient's engaged, then they're going to be engaged with this too. If the provider's engaged with it, it's probably going to work out better. And I think that gets back to the point that this is really just another way to deliver services. It's not necessarily that unique. It relies on the patient-doctor interactions and how they do over Zoom versus in person. And we may find that people divide up on how they want to treat these patients. And you may have a person that's great at Zoom doing that for part of your clinic. I think that's happened in a few large systems where they've created providers that mostly do Zoom calls and don't see as much in-person visits. So we are open and looking to learn what your concerns are from your perspectives. So feel free to type those into the Q&A there, or to email us if you need to. Any other questions?
Hey Morgan, this is Aaron.
Yeah.
There's a question that came in. It says, perhaps consider SIE building into their program telehealth, such as Teledoc or Amwell versus leaning on local providers?
Yeah, I think there's been a lot of large, I think I called into Concentra's talk at one point too around them building telehealth programs, purely telehealth, call in anytime kind of triaging things. I think there's a lot of innovative things happening in those spaces, and it'll be interesting to see how certain self-insureds deal with that. That's a good question. So I see Tricia has a question there around the older population. Yeah, I think that's a good one too, and that's hopefully what we kind of want to learn is, you know, who is using telehealth and who doesn't want to use telehealth, and are there certain reasons for that? And then what are the creative solutions to get around that? Whether that's on-site at certain medical facilities, providing them with technology that's a little more reliable or easy to use than what they have at home. You know, if it's a dedicated setup thing where the only thing you can do on there is telehealth, like Dr. Harris is kind of talking about, then maybe that's one of the solutions that certain insurers or providers or companies come up with, and then whose responsibility is that? And I think there's a lot of, you know, legal and you know, implications for that around who does that. And is telehealth, you know, is telehealth a right? Is it an access issue? Is it, how do we use it? And I think that's something that we all need to kind of discuss in that community too, is you know, I think I tend to look at it as a modality that may or may not work for certain people. And I don't know if it drastically changes their ability to access services by having it or not, especially when you take into account the idea of that there are places where you can go to perform these telehealth services. And maybe we'll see an increase in the number of dedicated telehealth rooms where people can then go to and call into a number of services across the state as a way to create that access without providing technology to a certain person or individual, and already have the ability to pay for and do those systems currently. Then it gets back to the question around what is telehealth, and is all telehealth created equal? Are there certain differences in the quality of connection, the quality of video that are preferable for certain things over others? I don't think teledermatology works as well with your phone or many phones and poor connections as it does over those high definition cameras with bright lights. Our dermatologist actually preferred doing telehealth because he had fantastic lighting, fantastic cameras. The images were right there into his charts and records, and it was faster and more efficient for him than regular visits. But he had a good setup. And how does that affect you if you don't?
Okay.
Thank you.
Thank you, Dr. Young. It looks like we are heading into break time next.
Yes, it is time for another break, a little opportunity to stretch. So during the break, there will be some slides on the screen giving information about the preferred worker program at the Department of Labor and Industries and the benefits for employers. If you would like more information, you can go to the LNI website and search for Preferred Worker Program. The chat window will be available during the break for all attendees to interact and comment on the colloquium so far. It is 11:34. Let's make it even. Go to 11. We will see you back at 11:45. Thanks. Okay, welcome back. So next we have Chat with the Docs, which is an opportunity for the self-insurance community to check in with the LNI medical directors on issues and ask questions live. So Kim Wallace is going to moderate this section for us. Kim is the medical administrator in the office of the medical director here at LNI. She has an MBA from Wharton and a BS in clinical dietetics from the UW. In the past 20 plus years, Kim has held various public and private sector leadership positions in healthcare policy and finance, health IT, health benefits management, and public health. I'm going to turn it over to you, Kim.
Thank you, Lene. Can everyone hear me okay? I hope that we have a good time over the next 40 minutes or so. I think everyone knows that the drill by now, that you can type questions in the Q&A, and I will watch the questions and read them out loud for the physicians to respond to. I have the good fortune of working with the physicians, 3 of whom you've already met. And I think that Dr. Gary Franklin, our medical director, you have met in the past as well. So I would like to start off by asking each of the physician panelists to just do a very brief introduction of themselves. Gary, let's start with you.
So Kim, I don't think that's can somebody open my video?
Gary, if you look down at the bottom of your screen on the left-hand corner, you should see something that says Start Video.
Yeah, when I do that, it says you can't start your video because the host has stopped it.
Okay, let me see what I can figure out.
Okay, I think I got it.
There you are, Dr. Franklin.
Yeah, so anyone that wants to join me in my corona while we're here. So I'm Gary Franklin. I'm the medical director. I'm a neurologist, and I'd be particularly interested in neurological questions, but we have a team here that will introduce themselves with their own specialties. So we're looking forward to a rich conversation here.
Thank you, Dr. Franklin. Dr. Joel McCullough, you heard from earlier. Just very briefly reintroduce yourself, please, Joel.
Yes, my name is Joel McCullough. I'm Associate Medical Director here at LNI, and I work with the IME program, medical consultants, and do work in impairment rating.
Thank you. And Dr. Jason Fodeman.
Hey, Kim. Hey, everybody. I'm Jason Fodeman. I'm our Associate Medical Director of Innovation and Outreach. And I am an internist, and I've practiced primary care. So really looking forward to the conversation today.
And thank you. And last but not least, you just heard from Dr. Morgan Young. Please reintroduce yourself.
I am Dr. Morgan Young, the Associate Medical Director for Chiropractic, and I best on questions about conservative care, including PT, OT, chiropractic, or behavioral health.
Okay, great.
Morgan has a lot of knowledge about behavioral health types of barriers to recovery. So he's been working on that for a long time. Dr. Fodeman knows a lot about the chronic opioid issue. He's been working on that with Jamie Mai quite a bit to try to help those folks that are on chronic opioids. And Dr. McCullough is also, as you've heard, an infectious disease expert. So if you have any questions related to infectious diseases, he'd be the guy. So just a few other things there.
Okay, thank you all. When I review the questions, try to call on one of the physicians to be kind of give the initial response. And then I'll pause just a little bit to see if there are others who want to chime in to add to the information. Now the first, I see Philip Levine, please excuse me. I see that you have put three questions in the Q&A, and I think they're related, and somewhat, they're a little bit lengthy, but let's just dive in. So the first question that you've submitted is, why is the department allowing claims for a 14-day quarantine period when a worker who is not a first responder has tested negative for COVID and has no symptoms or physical condition related to any contact with someone at work who did test positive? Both the statutory definitions of occupational disease and industrial injury require there to be a condition that is a direct and proximate result of an exposure. This does not seem to be the department's approach in any other type of claim, i.e. not requiring proof of a condition caused by the work exposure. That's the first. Let's see what response we can provide, information we can provide regarding that. And then I think there are a couple of related follow-up questions. Gary, I think that you may be able to best address this. And then also, I know that we have experts in our claims administration section that are, very much in the lead when it comes to exactly how to manage claims. And there's been a lot of special attention given to the rules and the policies around COVID-related claims. So there may be portions of this question that are best responded to in follow-up to this time with the docs that will require us to tap into our claims colleagues. With that said, Gary, do you have remarks to share?
Well, I did actually already partially this in the Q&A box. L&I does have Q&A on its website related to this question, but the main issue is that L&I feels that if someone is either in an employment that is high risk per se, such as a first responder or a healthcare situation where there is exposure, or even if you are working around someone that has tested positive, then our policy would allow quarantine with paid time loss for 14 days. And so you don't apply the normal rules of occupational disease in this situation for obvious reasons. This is a different kind of a situation, and L&I has followed the lead. I don't believe we're the only ones in the country that are doing that. And I know that a lot of other states have actually passed presumptive coverage laws, at least time limited until maybe next year, that would mandate coverage under these kinds of circumstances. Our legislature hasn't done that yet. I think there is some thought about that going on. So we feel like we're doing the best thing that we need to do under the circumstances. And it is, in regard to the exposures, the smart thing to do. We think that the risk in those situations is way higher than community risk. So you could say that if that's all true, either you're working in a high risk employment, or maybe you're working around a lot of other folks that are maybe at risk themselves, or that you're exposed to someone that is positive in your workplace. Those all make sense to me. And I know that there has been some contention about that, but that's not my area, the contention part.
Okay, I'd like to go on because there is second part to the question. If you are responding to a directive or pressure from the governor's office, please provide the employer community with a copy of the specific directive that says the worker is not required to provide medical proof of a condition caused by an employment contact as the basis for a compensable claim. Is there a specific written policy from the director of the department that says this should be the new compensability standard in COVID cases? If so, isn't this a legislative function to change the definition of what is required for a compensable industrial injury or occupational disease claim? That's related to your remarks, Gary. Do you have any additional comments?
No, I don't. I think, I don't know if the claims folks want to add anything to that.
I think that's additional follow-up that we can provide. And then third, is there a person at the department who is in charge of determining department policy regarding adjudication of COVID-19 claims? Is there a specific assistant attorney general who is the primary advisor to the department on these issues? So I think, again, we can provide contact follow-up with information about the people, the structure and the agency and how we're making these policy decisions. We'd be happy to do that. As you know, Vicki Kennedy is the assistant director for the Division of Insurance Services and oversees, workers' compensation. And of course, Joel Sachs is our director. We have policy leads, et cetera, as well. So I think that you're asking for confirmation that who among the leadership is on point. And so it is, I believe that, that's, we'll follow up with confirmation of that. And the fourth comment from Philip is thank you. Okay, well, you're welcome. Okay, and there is another question. The department needs to rethink HSA's policy that will not allow hearing loss claims to be performed via telemedicine. I have already put forth a system to do these evaluations with HSA and Dr. McCullough. All important aspects of the clinical exam, hearing tests, and paperwork can be done via telemedicine for the majority of patients who apply for a claim, many of whom are over 50 years of age at high risk for death and severe COVID-19 sequelae. HSA has discussed billing issues they would have, and I showed how this is resolved. With accelerating COVID-19 cases, things really need to change at the department level regarding this issue. Happy to discuss further with the department.
So this is Gary, could I ask whoever asked that question, I think it might have been Dr. Slutsky.
Dr. Slutsky, yes.
If there's any published papers that have actually addressed this problem, are there any peer-reviewed publications that have addressed this? Because I haven't seen anything like that, but Joel McCullough, did you take a look at this?
Yes, there was conversation several months ago and with HSA regarding the specifics of this. Yeah, I think there was a decision, but certainly I'm willing to revisit it if that's something that we're willing to do. So if additional information that we haven't evaluated, I'm certainly open to that.
Thanks, Joel.
And Dr. Slutsky is putting in the Q&A that we'll try to see if I can find some and submit. Thank you very much. And follow up on the first question was to please note that in the first question about the allowing COVID claims, that the employee the employee is not working in a high-risk employment. They are not first responder. I think, Gary, you mentioned other healthcare workers as well. But
I also mentioned that if you're an employee in any employment and you're exposed to someone else in the employment that does have COVID or it does test positive, that's another situation. That's not exactly the same thing as being in a high-risk employment, but that is another possible exposure scenario that we would look at.
Okay, there is another COVID-related question. Do you see Washington expanding the presumption for COVID-19 claims like other jurisdictions beyond limitations in place currently on high-risk employment or healthcare? And if so, to what extent?
Well, of course, that's up to the legislature, and I know that there is some legislative interest in that. We have gotten some questions on that. I have summarized what has happened. This was a few months ago now. Summarized what's happened around the country. A lot of states have passed some limited presumption, usually ending next year. There's a lot of nuances to that. A few states have passed those presumptions with also protections for employers from lawsuits. So that is frequently also part of the conversation, but I actually don't know what our legislators are thinking right now. I don't know if we've seen anything new.
But Dr. Franklin, you are sharing that you are aware there is some conversation related to possible presumption or some type of expansion. I think that's what you just confirmed.
Well, not recently. I mean, there may have been, we have gotten inquiries in the past, and I'm not really sure what the current situation is, so I can't speak to exact interest right now, especially with legislative session coming up.
Thank you. Okay. Next question is another COVID question. The guidelines under the COVID Q&A note a coworker to coworker was deniable. Is there documentation of what changed this guideline?
I know that this question, because I saw it in the Q&A, is coming from a contended case. And honestly, I'd rather not discuss a potential contended case, because I believe that there's already been a decision on that, and I'm happy to talk about it offline. I was not involved in that case, and I'd rather not provide any more conjecture about it.
Okay, thank you. Next question. Was Dr. Franklin saying if co-employee exposure, then coverage, I'm stumbling. If co-employee exposure, then coverage provided if not greater likelihood of risk from employment?
I don't understand that question. And what I said was that you could be in a high-risk employment, and that would be good enough if you're a first responder or if you're in a healthcare scenario. If you're not in a high-risk employment, you could also be exposed to someone who actually has COVID or who tests positive, and that would be another scenario that would have to be taken into account. I'm not saying, and of course, all the circumstances would be taken into account as to whether it ends up being accepted or denied. You saw the LNI's numbers from the self-insureds earlier and state funds, and the rejection rates are low, but they're not zero. So there is some rejection, and some of this is deniable depending on the circumstances.
Okay, thank you. And Lloyd Brooks is commenting that to everyone to stay tuned for the WSIA weekly legislative update. So thank you, Lloyd. So we do have a comment also from Vicki Kennedy. Thank you so much, Vicki. Seems these questions relate to claims adjudication and not necessarily to the specific work of the OMD panelists. And yes, I think that we were noting that as well. And so, you know, if there was a medical angle or a piece of information that seemed like it would be helpful to share, then thank you, Dr. Franklin. I think you've been taking that angle and sharing, but absolutely there are, you know, that at the heart of several of these questions really is about adjudication of claims and acceptance of claims, etc. So we would need to separate that from this panel and follow up with additional information after the session. I will look for any other comments that you would like to make, Vicki, to assist with the flow of the session. We also have, please provide contact information for Vicki Kennedy. Yes, we can certainly do that. And we also will be happy to put together some information for WSIA and to distribute out to everyone. There's another question. Can you discuss any, my question jumped around a little bit when I was reading it. Can you discuss any post-active COVID symptoms that our injured workers are exhibiting? So I think that relates to Dr. McCullough, some of the comments that you made. You were not sharing specifically about claimants, you know, and injured workers in Washington, but you were sharing the type of longer term symptoms that people do experience. Could you review that just briefly?
Yes, I don't have any specific on specifically L&I claimants and what symptoms they're experiencing. I only have information on what's in the medical literature, and but I wouldn't expect that there would be significant differences in what's in the literature from what you might expect from claimants. I mean, a lot of the symptoms related to fatigue, shortness of breath, memory problems, body aches, those type of non-specific type of symptoms, and they last for a variable amount of time. And since we're relatively early within the pandemic, we don't really know how they're going to play out. But many of the symptoms last for months, and they can occur in people with mild symptoms, mild disease, and severe disease. So, but I don't really have any specific information on claimants.
Okay, thank you, Dr. McCullough. The next question is, I think that this might be a tandem kind of response. Dr. Fodeman and Dr. Franklin, well, and actually Dr. Young, you have a significant role in this as well. So let's start with Dr. Fodeman, and then we'll move to Dr. Franklin and then Dr. Young. The question is, how does the OMD office educate providers on guidelines published or assist if providers are not following guidelines? So specifically in terms of provider education and opportunities for CME, I think Dr. Fodeman, you could start the response.
Thank you, Kim, and that's a really great question. And as Kim alluded to, you know, L&I, we do have a CME program, and that gives us the opportunity to offer continuing medical education entire guidelines, to CME, which, we hope, is kind of a nice carrot to, approve, improve, adoption, of our guidelines that we produce. Ultimately, kind of the vision of our CME and our provider education program, like pretty much everything we do in the Office of the Medical Director, is ultimately, to prevent, risk of harm and, to try to, protect our workers. As far as, actually disseminating the guidelines and trying to, just get them out. And, we spend a tremendous amount of time and effort, putting those guidelines together. As far as the actual, the dissemination, that's something that, we're working on and we're trying to, improve, to make sure that, the providers, in the trenches, are aware of that and, and that we get that important document to them. So, that's something that we're working on. Gary, did you have anything to add to that?
Well, I can guarantee you that the surgeons that are requesting things that we have guidelines on know very well about the guidelines, because every time they request a service through our Comagin utilization review service, they have the ability to link directly to the guideline that is pertinent to what they're asking for. We have a lot of data on how many of these are accepted, how many are denied, how many are appealed, and all that sort of stuff. I spend quite a bit of time, at least maybe once or twice a month, defending these denials when they're appealed. And we do have some legal basis for thinking that our network providers really should be following our guidelines. It's in our Senate Bill 5801 that was passed that established the statewide network, that all providers in the network shall follow our policies and guidelines and rules. And we interpret that to mean that the policies that we come up with are the standard of care in workers' compensation in our state. And I think most people actually are following that. But you're asking a great question about, do we have a regular way to let, say, all of the surgeons know when a new guideline comes out? For example, we're redoing the entire spinal surgery guideline right now for lumbar surgery. And it's been almost a year, and that should be done probably within about 4 or 5 months. And we do not have a routine way to let folks know about an updated guideline. We used to do provider bulletins, the old-fashioned way, printed provider bulletins that we sent out routinely with all this new information. But we haven't done that for a long time, and we do need to figure that out. We need to figure out a way to get this information out timely to the right people. And I would say that right now it's sort of inadequate.
Okay, and any additional comments that you have, Dr. Young?
Yeah, I think those are great points from Dr. Franklin and Dr. Bodeman around when we have different expectations, we have responsibility there to provide the outreach and support for the providers to excel in those situations. So I agree. We also do a little bit of outreach from us in OMD if there's chronic problems with a certain provider, or we have some, discussion or mentoring with them. So that happens on occasion too. Repeat offenses. So that's about all I have to add.
The next topic that I will talk about, and the reason it's on the agenda, SI joint fusion, is an example where a lot of trouble occurs, and even though it's not hundreds and hundreds of cases, it is increasingly a prominent area. So it's a great example, which I will talk about in terms of the nuances of this stuff. So.
Okay, I see that we're getting close to our end time, I think. I know there's some folks monitoring the timing. We have 2 additional questions so far. Let's see, Lloyd is asking, are there relevant conversations between the Office of the Medical Director and the state fund actuaries regarding long-term COVID cases? So I will just share that the Office of the Medical Director does receive data and analysis from the actuaries regarding the, their projections. And so we have an opportunity to interact on the, assumptions and timeframes, et cetera. So the short answer, I guess, is yes. And if you have additional, more specific questions or comments about the relationship between the clinical leads and the financial leads, please feel free to follow up with another question. Does any of the physicians want to add to that, to my comments?
No, we frequently will ask the actuaries to help us with various issues that come up over time. And I think it's been a regular theme this morning that we probably should revisit at some point about the longer term aspects of whether any of our injured workers who have COVID claims are getting sick, whether they're getting more prolonged symptoms, whether they're dying. I think we've had a number of deaths. I believe the first or second death in the state was an injured worker who was at that Kirkland nursing home who happened to have a catastrophic injury prior to that we were covering because it was a work-related catastrophic, I believe it was a quad. And they happened to get COVID in that nursing home where a lot of people died, and one of the first ones. And so we're really watching this thing like a hawk, and along with our claims partners, and very, very concerned about it all.
Yeah, thank you. And Lloyd, you followed up with a comment that COVID claim allowance for self-insurers is drastically disproportionate to the state fund. So I think that's, you were just sharing a little bit more about where you're coming from. Thank you. So I think maybe it's time for the last question. There's one more question here, and we are due to end this segment at 11:20. So I think we're coming in right on time. The last question.
Kim?
Yes.
Hi, it's Jennifer. We're going to give till 11:25 since we started this session a few minutes late.
Oh, okay. Well, trying to be all timely. Okay, sure. So feel free to add questions into the Q&A then. The next question is, has COVID affected opioid usage in our L&I claims? And I believe that, Dr. Franklin, I believe that you have reviewed some data on the effects on opioid usage that we've been seeing over the past few months during the pandemic.
I'm sorry, is the question what the impact of COVID has been in general?
On opioid usage.
Oh, we haven't, I don't believe we've really seen a big impact. There might have been, you probably know that one of our biggest issues is that we have about 4,800 claims in the whole state fund system. I'm not sure what it is in self-insurance on crime. And so we're working hard to try to help those injured workers and find a few willing partners in the community in terms of health systems and primary care docs and pain docs who are willing to help us work on all of that. You probably know that we have this PCORI grant that we have been interviewing several thousand workers over the past year, including starting in March. We added questions on COVID related stuff, and aside from impact on work hours and things like furloughs, which everybody understands has happened, there was actually very little impact on the responses from the injured workers on what happened in their medical care. So we actually have not seen much impact of that in regard to other medical care.
Okay, well, I don't see additional questions. And so I think maybe just open it up for some final remarks that, that any of the physicians have came to mind that might be helpful for the group, given the questions that have been posed. Is there anyone? I'll just open it up. I'll see when you unmute yourself if you'd like to make any closing remarks.
Well, I think, obviously the COVID thing is extremely high interest, and I think we need to keep it in front of us, be completely transparent about it, and continue to have conversations about it. I think even when a vaccine comes out, sometimes a vaccine works half the time or 75% of the time. So you still may have issues going on even after a vaccine comes out. And then we'll have all of these, several thousand cases that have been in the system, some of whom could develop longer term symptoms among those who actually tested positive. So we have a lot to keep our eye on here. And I want to thank everyone for your poignant questions.
Thank you, everyone, very much. It was a pleasure to get to interact with you. Not quite the same as being in person, but we're doing our best and pressing on, right? Thank you so much.
Thank you. And now we're going to transition right into Dr. Franklin talking about emerging issues with SI joint function. Dr. Franklin.
Okay, can somebody put my slides up? Here we go. So this is sacroiliac joint fusion, which is a procedure which was pretty much unheard of, 5 or 10 years ago or 20 years ago. We've had over the years, severe problems with lumbar fusion, which is a fusion between any one of the lumbar vertebrae, but this is a fusion between the sacrum and the ilium, and so it's sacroiliac joint fusion. And unfortunately, in my view, this fusion issue is based on patients' ongoing pain, sometimes from prior spinal fusion or prior surgeries, which is a real problem because they didn't get better from the first procedure or the second procedure. And now the surgeon is saying that they want to do another procedure, this time at the SI joint. Next slide. I've mentioned this before that, workers' compensation is not known for the best medical care in some cases, and the outcomes of procedures in workers' comp is in general worse than the outcome for the same procedure in non-workers' comp. I'm sure the same thing will be found it has been found with lumbar fusion, and there hasn't been anything published like this on SI joint fusion, but I'm certain that if that is studied, the same thing will be found. The next slide. I want to, I've shown this before, I believe, but I just wanted to talk to you for a minute about why we go to so much trouble coming up with our evidence-based policies, such as guidelines and coverage procedures through the health technology program or through our own decisions. And the reason is that federal oversight of all of this healthcare is pretty limited. The feds, the Food and Drug Administration, has oversight of drugs. I wouldn't, 2 randomized controlled trials, 2 high quality studies are required for the FDA to approve a drug. And then the drug is approved for specific things. But once the drug is approved, for example, when gabapentin was approved for neuropathic pain, It was based on studies related to things like postherpetic neuralgia. It was never approved for or shown to be effective for non-neuropathic pain, such as low back pain. But most of the gabapentin that we were asked to pay for when it was first approved was gabapentin for back pain and non-neuropathic pain, which was never proven for, and in fact has never been proven for. So this off-label drug use is most of what we get. It isn't the use that is approved for use by the FDA. The FDA's oversight of medical devices is way worse than that, much looser. 95% of new devices, such as the kinds of pieces of triangular metal that are implanted for SI joint fusion, are approved by the FDA based on substantial equivalence to a pre-existing device before 1976. So no new study is done for those devices that were approved based on that, what's called the 510K approval process. And that is 95% of the new devices are based on substantial equivalence. So they don't require any study at all. There's no data on that stuff. And then most medical procedures, most surgical procedures, there's no oversight at all. So this more or less leaves it up to public payers and other insurers to come up with ways of dealing with all this. The next slide. And I'm proud to say that in Washington State, the legislature and the governor's office have had a long history of various programs that have dealt with most of the aspects of what we should and shouldn't be covering in our insurance programs. The first one was the prescription drug program, which has been the longest standing program. It came around in 2003. Jamie Mai, our amazing pharmacy manager, and our team, along with that program, right now, the drugs that we're using, we're at 97% generic use rate, which means that the generic drugs in every drug class are just as effective, and the risk profiles are the same as with the brand name drugs in almost all cases. So we have used the evidence reviews from that prescription drug program to establish the state formulary, which has led to preferred drugs in our system. The next big thing that occurred was in 2003, the legislature passed a bill that asked all of the agencies to work together on evidence-based medicine and formal assessment of scientific evidence. So this was really the formal start of the agency medical directors group, which ended up working after that time on almost all of the opioid guidelines in Washington State. In 2006, the governor request legislation passed almost unanimously to establish the State Health Technology Assessment Program, which is the program that approves or disapproves for all of the agencies everything but drugs. So surgeries, devices, testing, things such as genetic tests for various things, which are getting more and more common, for example. So there's been a lot of that going on. And if you want me to do a more in-depth review for you of what the State Health Technology Assessment Program has accomplished and what they've made decisions on since it started, I'm happy to do that at one of these proceedings. And then in 2011, House Bill 1311 established the statewide public and private collaborative called the BRE Collaborative, which is really focused on developing and implementing guidelines. In 2015, the BRE Collaborative endorsed the agency medical director's 2015 opioid guideline, which made that guideline be sort of a statewide guideline for all payers. And we've done 4 other opioid projects in that environment, including developing metrics to track prescription opioid prescribing statewide. And the metrics that were developed in that effort are now part of the State Department of Health's dashboard on opioid prescribing. The next slide. Some of the of our state health technology assessment program coverage decisions. These are the things that have been determined to be non-covered. Things like upright MRI. This came around when if you're driving up and down I-5, you can see on the side at exit at the South Tacoma Way exit for the Tacoma Mall. There's a building there that is abandoned. It was going to be the second upright MRI building in the state, and this was a situation where people were doing MRIs supine, sitting, bending over, and we were getting like $10,000, $11,000, $12,000 bills on some of these MRIs instead of a $1,200 bill for a normal MRI. So that's non-covered because it was not proven to be useful. It did not improve outcomes, et cetera. Intrathecal opioids, you might remember, was a huge deal for a long time. That's not covered. Spinal cord stimulators are not covered. And then a huge decision in March of 2016 that lumbar fusion for uncomplicated degenerative disc disease is non-covered. That was as of March of 2016. We did have a Supreme Court decision in December, I believe, of 2018 that questioned some of these non-coverage decisions and recommended that we take a different approach at that. But what the Murray court said was that until we did anything different, that we did need to look at the cases individually, even if there was a non-coverage decision. So we are taking a look individually. We always do that anyway, but the proper and necessary standard, it must be taken into account. Next slide. This was in 2007. This was when the medical and chiropractic advisory committees were formed by the legislature, and they have the authority to advise on all matters related to the provision of safe, effective, and cost-effective treatments, including the development of practice guidelines and coverage criteria and technology assessments. So we use these committees very liberally, and that's why all of our guidelines are developed by the Industrial Insurance Medical Advisory Committee. The next slide. I mentioned earlier that Senate Bill 5801, which established our medical provider network, had a clause that said that network providers must be required to follow the department's evidence-based decisions, treatment guidelines, et cetera, and must be expected to follow other guidelines if that we didn't have one. The next slide. So if you just think about the conceptual framework here, we do make coverage decisions both internally and from the health technology program. If the coverage decision is that something should not be covered, then we would say it's not covered. Until the Murray decision, that's what we did. We still do that in some cases, but we also have to take into account now the individual circumstances, which we do. And so in applying our L&I treatment guidelines or the HTCC coverage determinations with conditions, when things are covered with conditions, that's how we apply the proper and necessary standard under those scenarios. The next slide. And since Murray, we've had to change that to include the HTCC non-coverage determinations to say that we need to take a look at the individual case. The next slide. So you all know that I've been very interested in lumbar fusion. The outcomes of lumbar fusion are horrible. This is a slide that shows what the long-term outcome is on lumbar fusion, that 10 years after lumbar fusion, 41% or more of our cases that had a lumbar fusion 10 or more years ago are permanently disabled on either pension for us or pension from Social Security disability. The next slide. So this is a horrible scenario. And then I just wanted to point out that when we apply our guidelines, surgical guidelines in our utilization review program, this is always prospectively reviewed. Request is from a surgeon. We have, and if it's denied, we have a peer-matched physician take a look at that. If a denial is recommended, there is an offer of an MD to MD contact within 2 weeks. And quite often, some of the requesting surgeons don't choose to do that, which I mentioned when I go to the board, the requesting physician must present clinical data that is significant enough to overcome the denial based on not meeting the guideline. In other words, they have to have substantial additional clinical information that would be compelling for us to make an exception in that case. And that would be true for the guideline. It would also be true for the non-coverage decisions. The next slide. So sacroiliac joint fusion theorizes that pain in that SI joint region is related to quote unquote instability of the SI joint, and that mechanically quote unquote stabilizing the joint with a screw or specialized device will decrease the pain. This is the same thing that was trying to be sold by orthopedic surgeons for lumbar fusion prior to this time. And the fact is that the pain in the SI joint cannot be generally differentiated from pain in any other part of the lumbar spine. And especially in candidates, the candidates usually include either surgically naive patients, they haven't had surgery before, but also a large number of patients that have had failed back surgery previously in our system. And now they want to operate on another part of the spine. I recently had a board case where there were 3 different levels of the spine that the surgeon wanted to operate on. And I can tell you that the surgeon cannot localize the pain to that extent. There are a variety of devices as well as screws that have been used, but the trial data is almost exclusively about a specific device made by this one company. It's called iFuse, and it consists of 2 to 4 triangular rods placed across the joint via minimally invasive surgery. The placement of these triangular rods is, they can't see what they're doing since it's minimally invasive. It's not open, so sometimes they don't really place it in the right place. And I'll show you in a minute what that results in. The next slide.
Dr. Franklin?
Yeah.
Hi, it's Jennifer. You're at about the 10-minute mark.
All right, thank you.
Mm-hmm.
So there is no diagnostic gold standard for whether somebody actually has a condition that would require SI joint fusion. The inclusion criteria usually involve varying definitions of physical exam tests. They can bend this way, they get pain from bending that way, and the results of reduction of pain from an SI joint anesthetic injection. But this injection has poor reliability on the physical examination. It does not really work to predict whether it's positive or negative what happens from an SI joint fusion. And there's some more information here on that I can share with you if you're interested later. The next slide. There's no way to really nail down that somebody actually needs an SI joint fusion. So on May 17th, 2019, the Health Technology Clinical Committee made a final decision that there was such weak evidence on efficacy, mostly unblinded studies with manufacturer funding, substantial evidence of adverse events, which I'll show you in a minute, and no good evidence on cost effectiveness, which are the 3 main standards that of evidence that they have to make their decisions on. And they decided in the next bullet that in adults 18 years and older with chronic SI joint pain related to degenerative conditions, minimally invasive and open SI joint fusion procedures is not a covered benefit. The next slide. So these are, the FDA has a database called the MAUDE database. Anybody can look up things on the MAUDE database. It's an open, publicly available thing. So it takes a little bit of doing to figure out how to put the terms in and how to find exactly what you're looking for. But if you're looking for this SI bone infused implant system, if you looked, as I did in preparation for that health technology discussion, I looked just in November of 2018 and found dozens of cases of these. And these are just some examples. And this is these are words right from the database. During the installation of the first implant, the surgeon experienced difficulties with pin advancement and malpositioning of the implant. The implant breached the anterior cortex. The surgeon was unable to remove the implant, so he transferred the patient to a trauma surgeon who removed the implant. The next one was another case, and these are case numbers that you can look up. The patient had pain relief for 1 week before complaining about new radicular pain symptoms. The CT showed that the most cranial implant had breached the neural foramen and was pressing on the nerve root. The surgeon performed revision, removing the implant. The next slide. I just do one or two more of these. They're all pretty similar. In 2012, the left SI joint was done with 3 implants. The patient later reported no pain relief. And in 2018, a new surgeon removed all 3 implants using chisels, as they were all solidly fixed in bone. This is kind of blood curdling stuff, you know, as far as I'm concerned. The next slide. And the next slide. So I have more of those to talk about, but I'm not going to go through all of that. But one thing that some red flags to watch for whenever a lumbar fusion or an SI joint fusion surgery is being requested and things seem a little off kilter to you, remember, we don't cover SI joint fusion unless the patient has had an initial substantial trauma, like a fall from a height, with MR or CT evidence that the SI joint is definitely disrupted. This would not apply when the low back pain has been chronic and if there's been prior lumbar fusion. If there's a detailed neurologic examination, I often find that when we get these requests, there's no neurologic examination at all, except for maybe 1 or 2 sentences without any clear evidence of objective neurologic findings. And have the objective neuro findings been corroborated by more than one examiner and by multiple tests, such as does the exam fit with an MRI and an EMG? If it's repeat spine surgery, does the record indicate substantial improvement after prior spine surgery? Was there any documentation of that improvement from by using functional status instruments such as the PROMIS 8 functional instrument? If the patient has not improved after prior spine surgery, get a gadolinium MRI scan to document whether there might be extensive epidural scar tissue formation from the prior surgery or actual scar that has surrounded the nerves, which may be the cause of ongoing symptoms and what will be called failed back surgery syndrome. So you definitely do not want to allow an SI procedure in somebody that has a failed back surgery syndrome if you've documented that that is true. Does the letter requesting surgery contain a lot of scientific detail and references? We've seen letters that have come from various surgeons, 3-4 page letters with 10, 20, 30 references with detailed assessment of those references. I can guarantee you that those surgeons did not do that research and did not write that letter. They are getting these letters from the manufacturers and then submitting them as if they had written the letter. Sometimes the requesting surgeon themselves has a financial conflict of interest by taking substantial sums from the device manufacturer, and you should check Dollars for Docs or the CMS open payment system, which you can look all of this stuff up. The next slide. And these are just some quick examples of looking up the SI joint, the SI bone implant for SI joint fusion. This is the company that is the most prominent in making the SI joint implants. The amount of money, this is the total amount of money that they're paying to doctors. And you can see that it's more than doubled over the past several years. The next slide. We had a request, and this is again all public knowledge because this is all available online. This was from a trauma surgeon, not a spine surgeon, who wanted to do an SI joint fusion. Can you stay on that slide? And you can see that he went from taking not much money to taking almost $50,000 a year starting in 2019. And next slide. Almost all of the money was from the one company that makes the little triangular pieces of metal that you implant for an SI joint fusion. And so I actually ended up using that information in the board case that I testified in. And so far, we've been doing pretty well in that case. But this is really horrifying, the relationship between these companies and the surgeons and what might be motivating them in some way. In this case, a trauma surgeon really doesn't have much business doing spine surgery. That's not what they're trained in. But in this case, we had a request for an SI joint fusion from a trauma surgeon, and this was his what he was taking from this one company. I think that's the end. The next slide. So I think I'm almost at the end of my time. How much time, do I have? A few more minutes?
Yes, you do. You have about two to 3 more minutes.
So I'm happy to take any questions that anybody has on this. I know this is kind of shocking stuff, but it's a newer procedure that didn't really exist 5 years ago, and it's another case of procedures being driven by technology that is said to be promising.
Dr. Franklin, this question came in. What is the best way for a TPA or self-insured, self-administered program to refer a request for treatment to be reviewed by the OMD?
Well, I would recommend you go through the SI section, but you can ask for any particular case to be reviewed by us. We're happy to do that. And I have occasionally been subpoenaed to testify in, occasional self-insured cases.
Another question came in. I understand that the spinal surgery guidelines are in the process of being reviewed/updated. Do you feel that with those updated guidelines, a decrease in SI joint fusion requests will result?
Well, it's already not covered, SI joint fusion, but I think that once we move forward with these new guidelines, I think the new guidelines will cut down on all manner of inappropriate spine surgery. For example, there's stuff in the new guideline that basically says that you shouldn't really be doing a second or third or fourth spine surgery unless the patient substantially improved from the last one. And we all know that doesn't happen. It does recommend getting the gadolinium enhanced MRI to look for the scarring and for failed back surgery syndrome. So there's going to be a lot of new stuff. The surgeon team and the IMAC subcommittee that's working on that are tremendous people. It's going to be a very thoughtful and more conservative guideline.
And those seem to be the end of the questions.
Well, thank you, Owen. I'm happy to take questions offline also after this is over.
Thank you, Dr. Franklin. And I think we're on to closing remarks.
We are into closing remarks. So I would like to invite Matt Saxon. He is president of the Washington Self-Insurers Association, and he's going to share a few closing remarks with us.
All right, so try to get my video working here. Thank you. I hope everyone can hear me fine. Starting out, I'd like to thank the Department of Labor and Industries for holding this first virtual colloquium. I would hope everyone would think this was quite the success. Great attendance, great topics, and it would have been a shame to miss out on doing this given everything that was happening, but understandable if we did. So much gratitude for you guys for pulling this off. Thanks to our speakers for sharing their knowledge and insight with us today. A lot of great topics. Just some observations of COVID-19. As much as we'd all like to not spend time on COVID-19, I'm sure we're tired of it. The presentation today is really a great reminder of how serious this is. I don't think a lot of people outside of our community understand that, and how we can't become complacent with dealing with COVID, especially after so long of doing it. Telemedicine, great topic there. This morning I saw an article on how the pandemic has accelerated online shopping and digital retail. But I think this has also had the effect on telemedicine and really pushed it to the forefront. And with that, greater utilization always results in greater innovation and ease of use. So I'm really excited about where this is going and how this could continue to be used and grown in the future. Let's see. Chat with the docs. I mean, what a great opportunity to ask questions directly to experts right in the comfort of their own homes. So thank all of you who are on that panel for inviting us in and giving us an opportunity to ask questions. Heard a lot of great topics there. And then finally, Dr. Franklin for ending with the SI joint fusion. I think that really highlights our eternal battle between what a patient may need and what some medical providers may want to provide. So if it's not this, it would be something else. So I'm really looking forward to the new guidelines and seeing what's out there and hopefully cutting down on some unnecessary procedures without good results. Let's see, finally, I'd like to thank our attendees who are here today. I do miss the handshakes and maybe an occasional hug from seeing everyone in person. But you know, it's a great reminder that while we may be isolated, you know, we're not alone. So I encourage everyone to reach out to your peers, spend time, share notes, stories and whatnot of how we're getting through this and how we're, you know, doing our work. And with that, I wish everyone good health and thank you all for being here today.
Thanks, Matt. So again, I'd like to echo Matt's thank you for a great day. Really appreciate everybody who joined us. The Q&A, just a couple of reminders, the Q&A and the chat logs will be made available for you as well as the PowerPoints. And again, this has been recorded, so if you had to step away, it will be available later. And you will also be receiving a short post-colloquium survey that will be asking for your input about how today went, and also will be providing opportunities for you to give ideas for future topics of interest. We really use the feedback from you to help develop our next colloquium. So we would ask you, you know, feel free with that. So again, thank you very much. Have a great afternoon and take care. Bye.